Damn, I'm live. Why is this guy always behind me when I'm live? Get out the way, fool! Get out the way! Okay, so. I'm thinking, right. I go through. By the way, I updated this so it's more better. So you can actually read it properly. Although half it's not even filled in, like, this is not even done. Um. Oh well. I need to do vaccines as well. I don't know any of these vaccines. Two doses offered at 70-year-old. Egg allergy, most can still receive. Meningitis B. 8 week, 16 week, 12 week. Do I have notes on that? Low weight for vaccines, I do. I need to go through vaccines because I mean it's low weighted, but better than nothing in it. Better than nothing in it. But I think first of all we need to go to CNS because I've forgotten all of CNS. 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 Wow. Yep. Not stored. Though very high can themselves cause neuropathy. Oh. Mm. So it can actually cause neuropathy itself if you give too high doses. Mm-hmm. That's an important one. I think I already know this one, though, to be fair, except I didn't know this bit. Okay. Well, let's go back anyway. Why am I jumping the gun? If you go to... Let's do CNS. Let's CNS. So it's hiding. CNS. Hey, what was that? Oh, never mind. CNS. Quite a few things here, but it is a big topic. Season types. I think I might need to add to the notes as well, because these are kind of basic. There's focal, seizure types, epilepsy. I don't want to like spend too long on them either. Okay. So focal, one side of the brain, muscle switching, and that's depending on where it is. Can be aware. Can spread to both and become a generalized tonic-clonic. Grand mal. Let me just put this. Focal can become complete loss of focal can become complete loss of consciousness. consciousness. One-sided. 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 One side of brain affected. Can patient can remain aware. Focal can become complete loss of consciousness. Yep. Absence. Is that just for consciousness? Consciousness. Oh, the S there. How did I forget you? That's the muscle one. I don't know actually how to like specifically say them though. Body goes stiff, the whole body. Petit mal. Bro, my flipping website is actually kind of good, man. If I do say so myself. Petit mal. Like, how is this? Like, how have I even made this? Petit mal. And it's where you get like a brief lapse of awareness. I feel like, doesn't everyone get this or no? Does everyone get absence seizures? I feel like I've had this before. Let's use type of seizure. Or is it not? Then what does everyone else get? That is similar to this? No. What does everyone else get that feels like an absence seizure? Just spacing out. Focal impaired awareness, seizures, or inattention. Just intense daydreaming. So that, okay, I don't know. Myoclonic is quick sudden briefs or jerks or twitches of the muscles. Sudden jerks of muscle. And carbamazepine and phenytoin in absent myoclonic may exacerbate them. Okay. Well, that did not happen how I wanted them to. Wait, the code is... What? The code is right though? I have no idea. Okay, let's do it like this. So the website kind of broke. It's okay. Okay, so is that gonna work now? Okay, let's see what that looks like now. It doesn't need that bit. Yeah, at least I know. Alrighty. Cool. Alrighty, okay. So I think I am confident with that one. So we go to the next one. So first line, what's AD? Anti-epileptic drugs? Probably. Levetiracetam and lamotrigine. First line in focal. Focal is the partial ones. What's GTC? Oh, generalized tonic-clonic. Sodium valproate. Restrictions. Lamotrigine if valproate is unsuitable. Absence is a toxoxamide. Myoclonic is levetiracetam. I think I can remember all that. Carbamazepine's never... Second line, okay, second line there. So you only use it in focal, really? What the hell's parampanel? So you taper over 2 to 6 months. So basically lamotrigine or levetiracetam for focal first line, then carbamazepine. But then carbamazepine is never for absence or myoclonic because it can make it worse. And phenytoin as well. What else is there? Nothing. Wait, what? I swear I clicked that like several times. Oh, do I have to make these? I don't want to make them. Yeah, there we are. Practice on. I don't know what's going to make me practice though. Structure points or table rows in this guide. I swear I was able to choose the practice before. Have I changed it? Bruh. Oh. So epilepsy, you do withdrawal with taper, so taper, 2 6 months. So let me just try and remember. So focal's levetiracetam, lamotrigine, and then carbamazepine second line, carba second, then generalized tonic-clonic GTC, sodium valproate, And then I can't remember what's second line for this. Maybe I think it's levetiracetam. I'll just keep that empty for now. Absence obviously was a toxophosphide. And then what was the last one? Oh yeah, myoclonic. Myoclonic equals, what was this one? I think it was lamotrigine as well. Let's see, what did I get right? Oops, I got it wrong. So it's, yeah, so GTC was lamotrigine. And then myoclonic was levetiracetam or valproate. Okay. I'll test myself on that later and taper over 2 to 6 months. I think I'm confident though, mostly. Or should I go with needs review? We'll go with needs review. Highest risk need initiation under 55. Any gender needs 2 specialists. Need pregnancy prevention program, full pack dispensing. Unless 2 confirm no alternative. 2 specialists rule no longer required for males already established on operate. So females already established, then they still need the 2 specialist rule. Women of childbearing prenatal annual review. Men, they just need 3 months. Always dispense a full original pack. So yeah, men don't need the annual review or the pregnancy prevention program. Wait, let me just check with this. Do females established need to use specialists every year or something? Oh, so if a female patient is already established on valproate but has never had a prescription signed up by 2 independent specialists, she'll need an extra review. I see. I see. Okay, I think I'm confident with that one. Commas being implemented and primidone induced CYP 450. I didn't know about primidone. Wait, let me go to the inducers. Also, I remember scrap GPS. What the hell is that? Scrap GPS. Oh, smoking. Wait, what? Wait, what? Wait, what's a sulfonamide? I thought that was... I hate when it doesn't give you what example straight away. Are these like trimethoprim? Yeah, trimethoprim is one. Is it trimethoprim and classic interaction? Yeah, hyperkalemia risk. and warfarin. Okay, let me try and remember. Sickfaces.com, isn't it? Sickfaces.com. I don't even know where it starts. These are meds that inhibit S. Something, then isoniazid, then carbamazepine, no. Inhibit clarithromycin, then ketoconazole, then fluconazole, then alcohol or amiodarone, then chloramphenicol, then erythromycin or other mycins except for azithromycin, then sulfonamides, then is it ciprofloxacin? I think it was. Did I already do ciprofloxacin? Man, I've forgotten these already. That's bad. Then O was zimifrazole. Then M was metronidazole. So it was sodium valproate, sodium valproate. Bruh, inhibitor, yeah, sodium valproate. Cipro, chloramphenicol, cimetidine. Is clarithromycin not one? Inhibitor or inducer. I'm sure it should be one. Oh, but I think erythromycin was the one that kind of says it. Proton inhibitor. Yeah, sickfaces.com. The E is for clarithromycin as well. Oh man, I forgot about that one. And then scrap GPS is sulfonylurea, carbamazepine. So these are inducers. Rifampicin, alcohol, chronic, phenytoin, griscofulvin. Gris. How do I remember Gris? Grisco. Hey, Grisco, man. Griscofulvin. Griscofulvin. And then Ason's phenobarbital. Oh, wait. Yeah? Oh, no. St. John's Wort. Man. I forgot a lot there. Sodium valproate was one. These are all induced. Recently combined oral contraception. Double level reduction with enzyme inducers. Okay. I kind of want to just see what this even leads to. Right, the BNF, that's really useful, mate. Whatever. I told basically the AI just to source it for me because I know the information is correct, but it did not do a good job. Oh well. All are teratogenic. Every single one. Hmm. Neonatal vitamin K. Mm. Are all babies given vitamin K at birth? While the NHS and WHO highly recommend that all, it is not mandatory. Parents have the right to decline. Hmm. Is it, and then this doesn't say and epileptic patients. How long folic acid pregnancy? Mm-hmm. Women taking anti-epileptic medication should take a high prescribed dose of folic acid 3 months before conception and continue first 12 weeks. What's the What's the actual nice guidelines? 3 months before conception and continue without throughout the first trimester until week 12. Where is it? Folic acid daily at risk. Folic acid 5 mg daily, 3 months prior. Months prior to conception and until 12 weeks. Save. Three months prior to conception and 12 weeks. Folic acid. Folic acid 3 months prior to 12 weeks pregnancy, and vitamin K to prevent brain hemorrhage. Interesting. Wait, do epileptic patients need that one? Baby vitamin K. Increased risk of vitamin K deficiency. Wow. Increased risk. Increased risk due to enzyme induces. So that's interesting. Vitamin K injection. I think I'll just put that there for now, but I think I know it. Primidone. Let me just write primidone because I always forget that one. Primidone. Status epilepticus, you have to use buccal midazolam. Oh, I would have known this if I actually did this. Would have known this on a test. Rectal diazepam. So IV lorazepam. Wait, why didn't that first slide tell me anything about status epilepticus? Status epilepticus describes any type of seizure that lasts too long, so for 5 minutes. Well, that's annoying. Stepwise treatment. It needs to last longer than 5 minutes. Any seizure that lasts longer than 5 minutes or repeats without breaks equals status epilepticus. So in community, you can give buccal midazolam or rectal diazepam. Then hospital first line IV lorazepam. Ongoing, you can give all these. Rectal diazepam. Community equals buccal midazolam. I think I remember that one. It's just the rectal diazepam. Rectal diazepam. Diazepam. And then hospital IV lorazepam. How do you even give rectal diazepam though? That seems invasive. So I'm gonna put in that review, and then I can go back to it in a bit. SSRI. Okay, so I've done seizures now. That's good. So I'm an eighth of the way there. It's been half an hour. 8 times like half an hour is 4 hours. It's gonna take me 4 hours to go through CNS. I think it might be worth it still though, because if I can get through this, then it'll be good, man. It'll be good for the rest of the exams. Wait, so what's high? Wait, so we got cardio. I think I really need to go to cardio again. Cardio, CNS, endocrine. I think. Okay. SSRIs are first line, tolerated better than TCN. Search line is the safest post MI. Fluoxetine only SSRI licensed in children. Fluoxetine's only one in children. I don't have those gaps. First line do not offer for severe depression. Safest post MI. Fluoxetine only SSRIs in children. I think I need to add about breastfeeding. Is the safest in breastfeeding? I think it is, right? Safest SSRI in breastfeeding. Sertraline paroxetine. Shorter half-life. Sertraline, first choice. Save. Bro, how am I revising off my own website? That's crazy. If I actually pass through this. So, wait, I've done the epilepsy one, so let me just go to SSRIs. I feel like there's got to be more to it. Maybe my guides are a bit too short. These are like general overviews, isn't it? Oh well. Depression. Let me see. Anything that I don't know here. Sertraline. Post MI. Fluoxetine children. Eight to 17. I think I know the rest. Let's go there. Next takes 2 weeks. Now 4 weeks. Or 6 in the elderly. We're switching for inefficiency. Really? Don't switch it before 4 weeks. Only switch post 4 weeks. Only switch after 4 weeks. 6 and elderly. Continue 6 months after remission. What does that mean? What does that mean? What does that even mean? I need to ask about it. After achieving full symptom remission, treatment should continue for more than 6 months. So wait. So you're saying if someone feels better after a month, they should not be taken off, they need to wait at least 6 months or 12 months before coming off. Correct. Stopping the medication right after treatment is a common mistake. So it's 6 months for normal people. And for depression, or 12 months for elderly or GAD. If a standard adult patient recovers from an episode of depression, it must continue at the same dose for a minimum of 6 months. Interesting. Remission rates are really high if stop treatment early. Let me just folding it in case someone doesn't know what this is. Generalized anxiety disorder. Is it generalized or generalized? Generalized. I think the British spelling is generalized. Or generalized. Is generalized the American one? I'm not using American stuff. The time extended to 12 months. Have highly persistent, long-term brain stabilization necessary. Brain stabilization. Disorders. Wait. Okay. Nice. And older adults need at least 12 months. Let me write that one then. What does that mean? Recurrent depression may need 2 months to need 2 years. Oh, just like. Confirm that if a person has experienced multiple depressive episodes, they should stay on the full antidepressant dose for at least 2 years. Wow. Wow. So I think what I learned from this one was, so continue 6 months for depression. You need at least 6 months. Elderly or GAD need 12 months. I feel like I've seen people stopped at 9 months, which is interesting. And recurrent equals full dose 2 years, and you can't switch for 4 weeks. Cool. Let's put that there for now. I say that, and then like half of these are all being put in this need for review. That's not very good, is it? That ain't very good, is it? Antidepressant suicide risk. Use suicidal thoughts, but the entry fast and early and monitor for first 2 weeks. First 2 weeks. I think I know that. First 2 weeks it is though. First 2 weeks increased harm. SSRIs. Or any other apparently. Paradoxical. What was that paradoxical thing earlier? Oh, it's left my mind. Man, oh, it's left my mind. I think it's something to do with Primadone. No, it wasn't. It's that high doses of paradoxine can cause neuropathy, even though it's supposed to protect against peripheral neuropathy with isoniazid. Cool, Leo. Anyways. What the hell is this? Oh, serotonin syndrome. Hypothermia, sweating, altered mental state. Sure. Monoxidase, wash out. SSRI plus triptans, tramadol, St. John's wort. What does this mean? Introducing a patient to or from a monodexase inhibitor. Washout periods are required. They prevent patient 2 or more oxygen to this. 1 to 2 weeks. 5 weeks. Patient must wait at least 2 weeks after a final monooxidase inhibitor before starting any other depressant. Wait, is tramadol an inducer? Or inhibitor? Is it one of them? Tramadol is an inhibitor. That's not even on the sick faces. Inhibitor CYP enzyme. Is not an inducer or inhibitor. Okay. Example. Paracetamol, the gleans. Okay, so this doesn't make any sense. So 2 weeks, at least 2 weeks after stopping Resiglane. So you need more than 2 weeks after stopping these, or 2 weeks after stopping SSRI. Oh man. 2 weeks before. Yeah. So linezolid, triptan, St. John's wort, tramadol. What do you get? Clonus, hypothermia, mental state agitation. You get tachycardia. What's clonus again? Is that the muscle one? Muscle contractions and relaxations. So clonus, hyperreflexia. Over exaggerated response. Over exaggerated response. So over exaggerated response should be it. I don't think over exaggerated. Is that even a word? Over exaggerated. I don't know. Exaggerated is the word for over doing something, so. So it's a lot of muscle effects. NMS. Signs of serotonin syndrome, where MS is characterized by sluggish, specifically lead pipe and diminished reflexes. And you get that from withdrawing Parkinson's meds. Which you can get more from Parkinson's med. From dopamine, from sudden withdrawal of dopamine agonists. Antagonist, sorry. Lead pipe rigidity. Lead pipe rigidity. LMS equals S serotonin syndrome equals more interactions in it. Multiple serotonergic agents. Do-do-do. Do-do-do. Oh man. Go, 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 go. Oh man. Alright. We carry on. Only switch after 4 weeks. Wait, is this not even updating? I'll do it. I'll check that later because I don't want to lose position. In guide 10 out of 4 is 1 hour. Is it going to take 6 hours? It's because this one took so long. So you can get from having SSRI / SNRI plus tramadol, Maui, Lanzolid, Triptan. St. John's wort. So that's serotonin syndrome. NMS is from suddenly withdrawing Parkinson's. Suddenly stopping rigidity you get with this one. And with that one you get hyper reflexive. What's the other one? Twitching. Suddenly stopping dopamine antagonists. What's the? Oh yeah, wash out. So Resiglene. So you need to just like stop that for like 2 weeks. Stop 2 weeks. Or stop SSRI 2 weeks. Or fluoxetine 5 weeks. Oh, what happened? No. No. Oh, this updated though. I know. No. Next. I know. I don't know. I don't know. Okay, antidepressant discontinuation. Taper gradually to avoid discontinuation symptoms. Paroxetine and venlafaxine have the highest withdrawal risk. Fluoxetine long half-life. Self-tapers. Taper slowly. Symptoms include dizziness, flu-like symptoms. Flu-like symptoms are sleep disturbance. Stopping SSRI, you get flu, dizzy, sleep. What's paresthesia? As I know. I know. I know. I know. I don't know. So abnormal tingling, prickling, numbness, pins and needles. So pins and needles basically. Sleep disturbance. Stop. Paroxetine. Highest withdrawal risk among exercise. Stop very, very slowly. Okay. Paresthesia. Parasectine at the worst. This is venlafaxine here. Oh yeah. I'll just write venlafaxine as well. I think I kind of knew this one already. Or flu-like symptoms I forgot about, but bleeding risk, yeah, I knew about this. Hopefully all of them are like that and I know them all. PSSD and hyponatremia. What's PSSD? I know hyponatremia. SSRI. Oh. Oh. That is not good. Why is there a whole Reddit for this? Please read. Wow, people are having lots of problems. Not good. Coma, convulsions, confusion, hyponatremia. What's SIAD? Again, too much antidiuretic hormone. Syndrome of inappropriate ADH. Too much ADH. Syndrome inappropriate. I guess that's what causes the lows. Symptoms typically stem from the low sodium levels in the blood. Wait, the low sodium causes more and oh, I guess yeah, you're urinating more, so you're urinating all the water so that your body can get a high concentration of sodium. Is that why? Is it because the body urinates more water to increase sodium concentration? Exact opposite. Oh, less water. So it's too little. Oh no, it's too much ADH. Forces. Oh, antidiuretic hormone. Oh yeah, of course. Extra water stays in the bloodstream. So you need to fluid restrict for this, which is paradoxical. Body can slowly get rid of the excess water. If it is though. So does the BP increase? No, BP does not increase. Retaining excess water does not increase it. Instead, it's euvolemic state. Appears normal. Drug when I not feel console on suicidal behavior. The three C's: coma, convulsions, confusion. Drug when I not feel convulsions, confusion. Convulsions, a coma. Natremia, hyponatremia. A syndrome of inappropriate antidiuretic hormone. So you keep too much water and take on sodium out. I'll never miss a World Cup match. Get the full schedule on your calendar. What? As the World Cup is now less than a week away, it's time to start planning how you're going to keep track of your games. Is that the most important thing? Really? Is that what we're thinking about right now? Coma, convulsions, confusion. How do I do that? It's 24 hours more clobbermide. And the corner of my eye. Right. Moclobemide. 24-hour washout. Parkinson's. Here we go. This was what I was waiting for. This is what it's all about. Stop bullying. Christ. Mao B. What's the difference between Mao B and a Mao I? What actually is inhibitor? And what actually B inhibitor? Monoxane A degrades serotonin. Ah, so Mao, so non-selective Mao I. So non-selective skyrocketed serotonin and dopamine, and they can be used for severe treatment-resistant depression. Well, I'm not gonna remember these though. How the hell do I remember phenylazine, phenylcyropamine, and isocarboxacid? How the hell am I remember those? Wait, selegline and restagline are monoxide B. This gets more and more complicated. Okay, I'm just gonna write it down. Then Mao I. So that's like phenelzine, tranylcopamide, tranylcypromine, and isocarboxacid. And these are all so they got the tyramine risk. Wait, increase serotonin, norepinephrine, and dopamine. Whereas monoxide B, only dopamine. It's like rasagiline, selegiline. Only increases dopamine. Do not use ergot-derived dopamine agonist first line. I forgot what that even is. I remember like hearing this ages ago, but oh, I remember this. Why did I remember this? So they have a risk of fibrosis. compounds, they resemble um um resemble or mimic in a chemical shape, mimic dopamine, but cause like thickening and failure of heart valves, cause fibrosis, e.g. thickening of heart walls, scarring of lung tissue. What you mean? What you mean? Mm. So quality of life. Mm, so quality of life equals co-carol-dopa. If no quality of life, then dopamine agonists like ropenolol. And I think they use a COMT inhibitor on top of that, isn't it, to make it better? That's not me. COMT. Mm. Mm. So COMT just really works well with it, but ropenolol just dopamine agonists. Mm. So you get impulse control disorders. Mm-mm. Mm-hmm. To delay the levodopa use. Dyskinesia is jerky movements. Jerky movements. Dyskinesia. So ICDs are impulse control disorders. Wait, I didn't even mark that one. What's modafinil? Unique wakefulness promoting medication. Huh. Modafinil is a potent inducer of CYP3A4. Wait, is modafinil the one that people use for studying? Yes, many people use modafinil. Oh dear. Um, can I use modafinil for studying? Hmm. I thought I remembered this name. Modaf. The phone vibrating. What was that? Okay, modafinil. the study drug. Sharpens focus, but SJS. Um, can make sleepy. So modafinil can be considered. Stimulant. I'll just put that gem in there. It's gotta be. Well, okay. I think I know this. NMS, yeah. Akinesia. That's restlessness. Oh my god, 18 out of 64. I think I went to the main one that I wanted to go to. Parkinson's. Parkinson's and epilepsy. And depression. What is even left? What have you got left? Phenytoin. Oh yeah, that's interesting. Lithium, yeah. So schizophrenia, yeah. We need to go to schizo as well. And I think antipsychotics is a good one to go to. Drug induced Parkinson's. Dopamine agonist. I do remember this. What do I remember this by? Oh yeah, this is EPS syndromes, isn't it? It's because they're dopamine antagonists. Mm-hmm. See how many I've done now. What is this here? Oh, is this the progress? Shouldn't this be green? Oh well. Do I not even have one of this? Should I try this? On CNS. Um, um, mm, one sec, chat. I just want to update something. Why can I not never find CNS? Am I just blind? Where is? Sorry, I'm addicted to using my toothpick. I want to update the topic list. That's what I'm trying to do right now. Um, Goodbye, big dirty base. Okay. Dexamethasone for adrenal insufficiency. Hmm. Hmm. I really should have worked on this before ages ago because I'm actually using this actually to learn stuff quick, but I made this way too late and it's so close to the exam now. No. It's actually useful as well. Dopamine antagonists cause drug-induced Parkinsonism. Antipsychotics typical and metoclopramide. Wait, what's typical and atypical? I've forgotten. Atypical versus typical antipsychotics. Atypical do both serotonin and dopamine. Yeah. So typical is like your haloperidol, chlorpromazine, and fluphenazine. Haloperidol, chlorpromazine, and fluphenazine. Those are your typical, and they cause your EPS symptoms more so. Right? Yeah. Typical cause EPS symptoms and tardive dyskinesia and random stuff like that. And hormonal side effects. Not good, not good, not good. Not good. So that's just the D2, whereas atypical equals D2 and serotonin. I feel like it should be the opposite way around, right? Because normally the dirtier drugs do all more stuff. Mm. So serotonin, that's got all of the other ones like clozapine in it. Oh, it's not listing clozapine. No EPS. EPS, hormonal. There's these ones just metabolic plus ED, I guess. Man, isn't that something to do with blood pressure as well? Ah, that's a bit too much to remember anyway. Especially typicals and FGAs. I don't know what the hell that is. Antipsychotic. Oh, for sure. First generation antipsychotics. Okay. And medical brain cause drug-induced Parkinsonism, worsen motor symptoms. No, what? What is this? What? Managing Parkinson's disease psychosis. These medications increase dopamine. Excess dopamine psychosis. Unless the standard antipsychotics block dopamine to stop psychosis. It can destroy motor control. So balancing these step by step. Okay. Gradually take them off the Parkinson's meds. Take them off the anticholinergics, mantidine. I forgot what mantidine is. Dyskinesia. So basically, to help treat the side effects. Monoxidase inhibitors, which are used for quality of life. They also increase dopamine, the dopamine agonist. Wait, what? No, they increase dopamine. Sorry, they're not dopamine agonists. Dopamine agonists is ropenolol and stuff. And then adjusting levodopa is last. Then you choose quetiapine or clozapine. Atypical antipsychotic. Do not heavily bind to the brain's to dopamine receptors, meaning they treat hallucinations without locking up the patient's muscles. I get two, I think, I get too curious, I think. I got the Curiosity Award. What's the psychosis though? What the hell? And then cool. That's a big change. What is this psychosis though? A severe non-motor complication of Parkinson's disease that causes patients to see, hear, or believe things that are not real. Hmm. As Parkinson's spread to the brain, it damages cells in areas processing things. Excess dopamine can trigger or worsen psychotic symptoms. Hmm. Ah. Uh. Dum 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 dum. Hallucinations, etc. Parkinson's drugs. You use the Parkinson's meds first, then you do quetiapine or clozapine, never olanzapine. Why never olanzapine? Yeah, actually, exactly like clozapine. Mm. Olanzapine binds much too tightly on the striatal D2 for too long. Okay. Okay. Julio. I don't know how this comes under drug-induced Parkinsonism, but yeah, needs to read definitely. So let me just write that clozapine and quetiapine are good, olanzapine bad. In Parkinson's disease psychosis equals quetiapine, clozapine good, olanzapine bad, naughty olanzapine, naughty. Yes. Okay, next. Antiemetic domperidone. Max 30 milligram a day cardiac QT risk. I didn't know about that either. Max 30 milligram a day of domperidone. There's a cardiac risk. Okay. Donepezil, galantamine, or rivastigmine for mild to moderate Alzheimer's don't stop because of severity alone. Rivastigmine. Alkyl esterase inhibitors. Galantamine, rare serious skin infections. It's now dementia in it. I guess I'll just put down the galantamine. There's SJS. Oh, what's the AGP? Explosives. Huh. SJS AGEP. Alright. Oh, I don't know that one. For sure. Memantine. I remember amantadine as well. Damn. There's too many different types of dementia though. There's Lewy body, I remember. Alzheimer's and vascular. Which one's the one that caused by Parkinson's disease? Parkinson's disease dementia. Oh, it's the own thing. I thought one of them turns into it. Oh, shoot. Damn. B12 levels cause profound confusion, memory loss, and nerve tingling. Interesting. Bro, how have I only got 2 here? Meow, 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 meow. What am I even waffling, man? What's MDA again? Sally Sassafras. What? Yeah. Damn. Damn. I'm literally chewing on my toothpick. I think this one I won't be able to get through. No. Memantine is after those lot. Rivastigmine and that. Then you go to Memantine for medium severe. Maximum 20 milligram day. Max 20. Then this is rivastigmine. These are all ACE acetylcholinesterase inhibitors. Oh no, that one's acetyl and this one's NMDA. I think. Inhibitor. Antagonist. NMDA antagonist. Can be combined. Then plus this one. Wait, let me just put. I don't know that one. Antimuscarinics worsen cognition. Wow. Risperidone's the only one. In which dementia though? There's no problem. There's so many dementias that this kind of doesn't help. So risperidone's the only one that you can use in dementia. For 6 weeks. No valproate. Okay. Wait, was I just limit? I hit the usage limit. What? How? So annoying, bruh. All right, let me just see what's going on. I'll be back 1 second. I just need to see something.
Oh man. Um. I still got to pray chat, so I'll be back in a second. It's just some other stuff came up. I'll be back though.
Okay. Sorry about that. I'm back. I play Pokemon Go every day. Sorry. I've got this oil between my hands, and if I rub my hands fast enough, it smells nice. I'm burning oil. Anyway, sorry. What the hell was that about? Oh dear me. Okay, so what were we? 22 out of 30, 64. Oh gosh. There's no guarantee I'll remember all this though, probably. Do I have highlighters? I don't think I do. Let me just see how much that has done. Not your usage rate limited. What? Claude, man, I barely even did anything with you. You stupid idiot. Claude 54% used. What? Compact. Not messages to compact. Continue. I'll just tell it to continue now. Why is it telling me I'm rate limited even though there's... Okay, whatever, man. Anyways, let's just continue with this then. Ooh, fidget spinner. Can you hear that? I don't even know if chat can hear that. Ow, my finger. What happens if I do this on top of the mic? Ow! Wait, let's try it again. Sorry, that sounds horrendous. I don't know why I'm even doing this. Oh no, I broke it. What the heck? No, why is it broken? Flip. Why is it broken? Ooh, that's a good noise. Why am I playing with a fidget spinner at my age? Anyways, let's carry on. What was I doing? Risperidone in dementia. 6 weeks. Yep. We agree. Oh wait, have I already done this? I've done this one? Okay, that's good. Stroke and death. Antipsychotics. So other antipsychotics, no, because stroke and death. Where? Psychotics, stroke, death. Yes. Not good. Alright, next. Wait, let me actually mark that as... What else can I remember about this though, really? Let's just put as... Confident needs review? I'll put needs review. Just in case. I don't remember. Anti-hypertension, anticholinergics can cause hypertension. Oh yeah, ACB review. I remember you having to do those. Anticholinergic burden. Not good. Sumab. Sedatives, postural drop. What's this? What even is that got to do with anything? New therapies. Oh, anti-amyloid. So that'll stop the dementia. That's pretty good, isn't it? Alzheimer's dementia will be no more with this, but risk, not nice, recommended for NHS. Risk of ARIA. Sounds like a woman's name. Risk of ARIA happening. What is risk of ARIA? Amyloid related imaging abnormalities. Unknown imaging visible. So, what even are they? Imaging visible brain changes that occur. Oh, brain changes. Oh gosh, that did not sound good. Alright, so I'll just leave that. I don't need to know that. Okay, I know this though, really. Anti-amyloid, blah, blah. What's this got to do with falls and risk medication review, though? Alright, I think I need to know this one, so let's continue. Schizophrenia, first line treatment. Oral antipsychotic. Non-mandated first line. No single mandated first line. Choose by side effect profile. And patient preference. Yes, I agree. Oral antipsychotics, CBT, family intervention. SGAs, what's this? Oh man, I literally just searched this up. What is an SGA? Oh, it's let me try and remember. Generation antipsychotics. SGA, I can't remember. Antipsychotics. I know the middle one's generation probably. Atypical? Oh, second generation antipsychotics. Oh, second generation. Okay, of course. Whatever. Well, how that was even hard. Okay. Better for negative symptoms. There is no mandated first line antipsychotic. Yeah, I think I knew that anyway. They got CBT intervention. Yeah, okay. I think I knew that. Next, clozapine after failure of 2. I think I know this as well. At adequate dose of 6 to 8 weeks. I got this right. FBC monitoring, risk of agranulocytosis, myocarditis, fatal constipation. Fatal constipation, you know. That's a bit mad. That's a mad one there, man. Why am I talking like that? Clozapine can cause agranulocytosis. Agranulocytosis. Myocarditis. And fatal constipation. Not good, man, not good. Imagine having fatal constipation, not good. Okay. Anything else? Treatment resistant, yep. What's this? CPMs. CPMS. What's that? CPMS FBC. Weekly for 18 weeks, then fortnightly for 1 year. Fortnightly to 1 year, then monthly after stopping. Clozaril patient monitoring service. I remember that rubbish. I mean, it's not rubbish. I guess it stops against it. What are they actually monitoring though? Just FBCs? What? Oh yeah, because agranulocytosis. So that means just the red blood cells and stuff. Not good, man. Not good. Agranulocytosis is for the red blood cells, right? Not neutrophils. Agranulocytosis. It's just every cell in it. Oh no, it's white blood. Oh, it is neutrophils. Wait, which one am I thinking of? Oh, agranulocytosis and neutropenia. I think they're the same in it. Okay, wait, what was I thinking of? Is it megaloblastic? I think I was thinking megaloblastic. Megaloblastic anemia. Anemia. What's that? That's just... Yeah, that's where the red blood cells blow up. Not good, mate, not good. Which drug causes this? Which drug causes that? Oh, it could be B12 folate. So, usually by interfering. So, drug-induced megaloblastic anemia could be methotrexate. Oh yeah, methotrexate and trimethoprim and that. Them lot there, yeah. Not good, man. Not good. Not good. So basically, all the ones that affect folic, and I wonder if metformin. Yo, I guess metformin as well. B12 because of B12 impairs B12 and lansoprazole. Okay. Yeah. Metformin. So metformin. Is the AI in the website doing better? Let me check. Wait, why are you a different Pokemon now? Did you change it yourself or? Wait, what? That's a bit random. I can check in a second. I think I was updating it right now, literally right now. It was I did update it. It looked like the whole. Actually, I think I showed you it yesterday. It looked like the actual GPHC website. The metformin, the B12, and folic, which could be any methotrexate and that. Oh, you're on a different account. Oh yeah, you are. Methotrexate causes megaloblastic. And then these ones cause neutropenia and that. Neutropenia. Let me see what it's the AI. I'm trying to get a different AI to update my AI right now. I'm trying to basically add a bunch of different topics and that I have notes on. And the more topics I have notes on, I think the better the AI is gonna get. So I'm just trying to add more and more and more. Let's see. I've just done genitourinary. Let me add immune system. I'm trying to just finish it off. So I'm on my laptop combing through my guitar center. Oh gosh, that sounds. Wait, I wonder. Like, you've been playing guitar for a while now. You could probably play most of the things, right? Or no, you didn't really play it that much. Immune system. Yep, that one. I've got malignant disease in the skeletal system and respiratory system after that. Gosh darn it. Gosh darn it. Now this. Okay. Immune system added. Alright, so I've been playing for 3 years. I don't actually know how long it takes to get good at guitar. I guess it actually depends. I mean, anything you can like probably like speed run it if you like just doing it 24/7, right? Although that would hurt your fingers. Guitar must hurt your fingers. Have you got like blisters on your fingers? I know some people have that flipping some people have like a long thumbnail. I was gonna say the what's it called? The cocaine little finger. No, not the cocaine little finger. People have like a long nail just to like sort out cocaine on the table, but not that one. I mean the long thumbnail. Takes at least 7 years to be professional. Oh gosh. You got the calluses. Oh gosh. Darn it. People use their thumb as a pick, isn't it? Is the protection against calluses probably just a pick? Okay. Neutropenia. I got long fingernails for classical playing. That must like rip apart your nails as well. Clozapine after failure of 6 to 8 weeks. Again, says myocarditis. First 2 months. Myocarditis 2 months. And supplied only by pharmacy registered with the monitoring service. Needs a current FBC before each supply. Myocarditis is the most common in the first 2 months. I think I'm confident with that, right? No, not really. Smoke induces. Ooh, induces, induces. I forgot to add that onto my thing. Scrap GPS is scrap, not crap. Inducer. Scrap. Not really, you'd think, but classical strings are made of plastic. So it's up there. Huh. Wait, you use a classical guitar. The other ones are the little like coil ones. I had one in like music class, I remember. It was like that, like really, really like long coil. I think it was a coil anyway. I think so. Yeah, that looked interesting. Yeah, I just like strum through it pretending I can play when I can't. Classical strings are plastic though. Wait, really? I thought they were like metal. Those thin metal ones. Wait, so do you have like a electric one or no? Wait, you have a classical one. No, you have classical strings, but you could use it on a. Could you use it on an electric one? I have no flipping clue. Probably you need metal for electric, probably. So not really. Anyway, smoking induces CYP1A2 lower levels, stopping e-cigarettes high levels. Why tobacco smoke? Switching to raises to reduce the dose. This infection also raises the levels. Wow, man. Clozapine who quit smoking can become toxic. Reduce the dose proactively. So smoking and clozapine. See, you have to remember all this rubbish that you'll never think of, but it's important, I guess. Smoking plus clozapine interaction. I have 7 guitars each. Why do you have 7? Aren't they really expensive? I swear they're so expensive. Unless you got like a lot of cheaper ones, but still, even then, that would still add up. 7 for their own niche. Oh my gosh. Extra paranormal side effects. Hey, what? I made this up myself. I made DAPT myself. ADAPT is this. Bruh. I made. I thought I was smart by creating my own abbreviation, but it turns out these guys have already made it themselves. Oh man, because I copied this. I copied some of these notes from somewhere else. ADAPT is okay, whatever. It depends where you get it. Yeah. Yeah, I think some musicians have their own one. Was it Jimi Hendrix? Does he have his own guitar stuff? Hendrix guitar brand. Fender Stratocaster. Or wait, he's I guess he just got his own expensive one, right? Oh yeah, I guess it's just which Strat sounds the most like Hendrix. With the Fender Stratocaster. Gibson. He very frequently used various Gibson models. I thought he had his own guitar brand at this point. Oh, so no, he just uses a Gibson model. In total, my whole collection of guitars, gear, and materials to help keep maintenance go well over 20. Bruh. 2,500. That's a lot. Hendrix doesn't own a brand. He uses lots of different things. Oh, well, I was completely wrong. I think I got confused because I think his guitar went on for like auction and it sold a lot. I think I thought that meant he had his own guitar brand, not that his guitar got sold. Which is very silly of me. Hendrix is a dead brother. Yeah, he is. I mean, doesn't mean he can't sell anything. Like signature models. Not good, man, not good. Smoking plus infection causes clozapine to go up. I think I knew this already though. Oh, what the? Where's my... No! Where did I use that off you? I nearly lost my pen lid. That'd been annoying. Acute dystonia, akathisia, Parkinson's, tardive dyskinesia. Yep. Tardive is often irreversible. Wow. I did not know that. And NMS. Actually, I need this one. I didn't know this though. That's crazy. Let me try and remember. What was my thingy? So, DAPT was. Oh wait, actually, I got this wrong. I'll put dyskinesia. Is dystonia first? What the hell is dystonia? Dystonia. Acute dystonia. Involuntary sustained muscle contractions. These contractions force parts of the body into abnormal. Ooh, that does not sound fun at all. So dystonia. Anyway, dystonia, akathisia, which is restlessness. You got the Parkinsonism, which is, you know, just Parkinson's symptoms like tremors and muscle jerking. And then you've got apparently hyperprolactinemia. So you can literally start having breast milk. And tardive dyskinesia, which is facial twitching and rolling off the tongue. Not good, man, not good. So dystonia, I didn't know, and hyperprolactinemia. hyperprolactinemia. HDAPT. I should call mine HDAPT instead. HDAPT. Alright. Okay. I think I know this one though, really. Next, atypicals cause weight gain. How do I know which ones cause weight gain? So clozapine and olanzapine cause weight gain. Olanzapine seems like a... I thought olanzapine was my favorite antipsychotic, but I guess not anymore. It seems like it causes a lot of problems. It's a strong D2 binder, I think. D2. What's it called? I think quetiapine and clozapine, they quickly let go of the receptor. What's that word called? I don't know. But olanzapine sticks to it, which is not good. Which is bad for... What's it bad for? Flip, I forgot. Oh yeah, Parkinson's psychosis. Parkinson's disease psychosis. Yeah, not good. Metabolics highest with clozapine and olanzapine. Lowest weight gain with aripiprazole. So, okay. Let's see. So aripiprazole is the best. What is your little guy saying? I don't even read chat. I just see the little guy say something. What the? I own a lot. 2 amps. Amps are expensive as well, I'm pretty sure. 4 pedals, 12 strings, acoustic back, mini acoustic, 2 classicals, a hollow body, and a Strat. Bruh, that no wonder it adds up to 2,500 because that sounds like a lot of different things. Acoustic bass. Acoustic. Sorry, I'm flipping. I've got flipping brain rot, man. I mean, anytime I see acoustic, I just think of. Anyways, yeah, Mashi's is acoustic. Let's just say that. But yeah, that's a lot. Acoustic bass. I think that'll probably be my favorite out of the ones that you're saying. Why you got 2 different classicals though? That's the same thing, isn't it? Aripiprazole is the best in terms of metabolic. Equals plus metabolic. Olanzapine bad. Clozapine bad. Minus olanzapine. Clozapine. I think it's good for... Olanzapine might be good for... Wild. No. Pretend we didn't hear that. Confident. I think I'm confident with that. Ooh, Pimozide. I didn't see this. So ECG before and periodically QT prolongation. Pimozide. I just hear these new ones that I've never even heard of before. How am I even supposed to remember that one? Pimozide, ECG QT long. ECG QT. My dad found one in the trash and gave it to me. The other my mother gave to me, to my father, which didn't use it, so he gave to me. Whoa, you found a working guitar in the trash. That's sick. Whoa. That'd actually be good. I'd take that home. I would, even though I can't play, but I'll just take it anyway. Because that would be annoying to get otherwise. Wait, your father can play as well though? That's good. Oh, well, actually your mother gave it to your father, but he didn't use it, so I don't know if he can play. Alright, so I guess clozapine and olanzapine carry the highest metabolic. Okay. Quetiapine oral suspension recall. Oral suspension was recalled for containing double the state active content. February 2026. That's recent. Double the label active content. Quarantine affected stock. Class drug recalls require. Whoa. I did not know that was a thing. Well, I think I know that now. Quetiapine drug recall. Double dose. not really working. It was cracked and stuff, so it was more of a project thing. I mean, still, you still got. Wait, can you take strings off a guitar and put it on the other one? That might just not work, probably. But still, I mean, if you don't have a guitar, a cracked guitar is better than nothing. So I would still take it home. Sertraline is the first line SSRI for generalized anxiety disorder. If ineffective, not tolerate, try another SSRI or SNRI. Pregabalin. Really? I thought pregabalin was more for neuropathic pain. Yes, it's not like they're glued on. Yeah, they have the what's it called? That, although wouldn't that be kind of dangerous taking them apart? It has the little like screws at the top, isn't it? That you loosen and then you can take the strings off. But that would like if you loosen it, can't you just like snap and hit you in the face or something? Wait, have you probably snapped so many strings now? That's dangerous, isn't it? Can go into your eye and stuff. First lines SSRI sertraline, then SNRI, then pregabalin. So GAD, sertraline, and then another SSRI, NRI, then pregabalin. Okie doke. Oh wait, I actually need to put confident for that one because I think I knew that already. Although I thought initially I thought it was citalopram. Citalopram was which one? Citalopram for depression, but I guess sertraline is better for both now. Is citalopram first line for anything? First line for anything. The strings snapping aren't dangerous as long as you're not dumb and just twist it until it breaks. Oh, if you tighten it too much. Yeah, makes sense. Makes sense. Bro, why is it giving me US guidelines? Flipping idiot. I'm not in the US. UK guidelines, dumbass. I only see sertraline. First line. Wait. I feel like fluoxetine should be first line. It's just a nice SSRI in it. Cardiac safety. Citalopram is more causes more QT prolongation, which is an electrical delay in the heart rhythm. Permanently capped to 40 milligram for adults and restricted to 20 milligram for anyone over 60 with liver issues. Those with liver issues. Interesting. So, citalopram, they reduced it because of the QT stuff. Citalopram reduced to 40 milligram because QT prolongation. And sertraline has an exceptionally safe cardiovascular track record. In fact, national guidelines from the SPS explicitly name sertraline as the absolute first-line choice for patients with a heart disease or ischemic heart disease conditions. That's coolio. Yeah. Let's see next. Oh wait, did I even tick that one? I think I'm. Wait, what? Oh, pregabalin is licensed for GAD when these are unsuitable. It is Schedule 3 controlled drug with dependence and respiratory depression risks, especially with opioids. Licensed for GAD if SSRIs and SNRIs are not tolerated. Schedule 3, max 28-day prescriptions, dependent risk, respiratory depression risk, especially with opioids. Pregabalin is a Schedule 3 CD with dependence, respiratory depression risk. I think I knew all this, to be honest. Is this doesn't even talk about neuropathic pain, which it's pregabalin for anxiety. That's why. So yeah, you just use it when the SSNRIs are not suitable. Fine. Benzodiazepines for anxiety. Yeah, I've seen that actually, to be fair. Only for short term, 2 to 4 weeks, relief of severe disability anxiety. Short acting agents preferred in elderly hepatic impairment. Strengthened dependence warnings. Interesting. Very interesting. So lorazepam is better than diazepam, that because of short acting. Lorazepam, shorter acting preferred. Myasthenia gravis, what was that again? Oh man, I remember just learning about that the other day. Frick, I forgot. I think it's something to do with full body skin reaction. No, okay, never mind. Oh my gosh, what the hell am I saying? Yo, that looks freaky. She looks like she's got a stroke. What? Myasthenia gravis is a chronic autoimmune disorder that disrupts communication between nerves and muscles. Interesting. Very interesting. So, they call myasthenia gravis. Contraindicated. Sleep apnea. Wait, they don't cause it, it's just... Oh, it's just an autoimmune disorder that you're not allowed to use it in. Myasthenia gravis. Severe hepatic impairment. Okay. I think I mostly knew it. For anxiety at 2 to 4 weeks minimum. Maximum, sorry. So 2 to 4 weeks max. And they're short term. Ooh! Ooh-wee! Sorry, I don't know why I squeak like that. Ooh-wee! Yes, sir, Bob! That hits the spot. Oh no, my flipping fidget spinner. Where'd that go? Yes, sir, Bob. Alright, next. Oh, flip. I think I'll go with these for review, really. I don't really know that, to be honest. Myasthenia gravis, sleep apnea, hepatic impairment. Let me just write sleep apnea as well. Sleep apnea. I thought that was a diet. No, my flipping fidget spinner is gone. It's hidden in the depths underneath my desk somewhere. I thought there's a bunch of rubbish under my desk right now. Not rubbish, but like items. I've got a PS3 here for some reason and a huge water bottle. I haven't said water bottle for so long. Sleep apnea, myasthenia gravis. What's the other lung one? What's the lung one? Pulmonary insufficiency, hepatic impairment. I think is better one to write. Hepatic impairment and pulmonary. I really should have revised earlier on. This is not good. This is just not looking good at all. This is really just not looking good. And I'm being sheepish. I'm being serious. Zopiclone, Zolpidem are Schedule 4 Part 1 CDs. Wait, let me just see how the AI is doing. AI! Are you finished? Are you finished? Yes, sir. Oh, Claude. Let me have a look. Claude, how are you doing, Claude? Claude, 70% used. Ah, I think I can squeeze some more out from you, Claude. Don't mind if I do. Upload some more. There we go. This one too, mate. This one too. So that's nearly the medium weight ones done, I think. Are they? Oh man, 3 more. I want to do respiratory, but that one's last on my list. Stupid! I ain't gonna let you get the chance. It's a legendary quote. I feel like no one knows where that's from. All right. Z drug schedule 4 part 1. Same dependence as benzodiazepine, short term only, avoiding the elderly. Not safer than benzodiazepines for dependents, short term use only. I didn't know the schedule 4 part 1, so that's a good one to write down then, I guess. Zopiclone, Zolpidem. Sound like flipping Pokemon. What's his name again? Zapdos? Zapdos? Give yourself a Zapdos of Zopiclone and you're falling asleep. Z drugs. These ones are quite good for getting to sleep though, to be fair. Well, that is in the name Z drug, but Zolpidem. Schedule 4 part 1. Schedule 4 part 1. Okay. Don't really know that, so I'll just put it there. Lithium range and indications. Range is 0.4 to 4.4 to 1. Actually, I needed to know this. This one's an important one. I need to know this. This is boring, to say the least. Oh man, I need to start revising early in the day so I have more actual, like, you know, time to actually do stuff. Oh, wait, what time is it? 8. So, by 9:30, I gotta move on. I can't be on this anymore. Shit, boy. Let's have a look. Is Claude done? Hello, Claude. Hurry up, slave. Okay, that was not good actually. I don't think I should do that on stream. Do not clip that, bro. Claude, man, Claude, hurry up, man. It's taking too long. Claude, bro. Man, this is why it's all Claude's fault. I said that. Blame Claude. Blame Claude. Flipping heck. Hormone responsive malignancy file. No, don't do that. No, I didn't get to. No, man. No, don't clip that, man. That was on accident. I shouldn't have said that. That is not a good thing to say. That's so dumb. No, do not. No, literally don't do that. Alright, hurry up, man. Why is it done yet? Sussing. What does that even mean? Claude said it's sussing right now. Sussing, unraveling, Clauding. 2 new topics: breast cancer and prostate cancer. Cytotoxic side effects. Wait, what? Oh, malignant diseases doing. Oh, I thought it was doing something. I was like, why is it doing cancer? Hurry up, mate. Hurry up. Malignant disease is done. Okay. Nice. Nice. Let's have a look. How much I've got left. How much usage I've got left. Let's see if we can squeeze some more out of Claude. What? It still says 70% used. Did it literally not use anything? Wow. Just absolutely absolutely fantastic, phantasmal. That's some absolute great news. Open musculoskeletal. Now do this one, musculoskeletal. Wait, is that just pain? Is it gonna just talk about pain stuff in the musculoskeletal? Same workflow. Yep. Play Bed Wars. Why are you guys asking me to play Bed Wars? Is that why you streaming Avatar? Can we watch? I don't think I want electric watching, to be honest. He's got his own exams. I don't have enough money for Bed Wars. Why do you need to practice? I came back to this. I think hollow bodies are some of the best kinds of electric guitars. Electric guitar, hollow bodies. I would have some absolute amazing commentary for that if I knew what flipping hollow body was and what are good guitars. I have no idea. I cannot say. No! My stocks! Shoot! Corning went down 10% today. Oh, flip. Oh, how much money have I lost then? Let's see. Uh-oh. That ain't good. Oh, no. That is one of the most biggest losses I've had. Okay. I mean, it's still up quite a bit, though, to be fair. Let's see. How much did I lose? That's only one profile. Oh gosh. That's about maybe $150. Okay. What other platforms am I streaming on? Yes, this one. I was just reading the Discord server. Are you still on the Discord server? I haven't seen you in there for a while. These guys just asking me. Bed was boring, ain't it? Bed was boring anyway, isn't it? I'm just typing on Discord. What should I tell him to get on? Oh, forget it. I was gonna troll him. Get on Club Penguin, that's where it's at. Anyways, let's see, how is Claude doing now? Claude. Why authored 2 files to our guides? Okay, nice, not bad, mate, not bad. That's not bad, isn't it? Usage 82% used. Ooh, okay. This is kind of good. Respiratory system. Let's do that one next. Now this. Okay, we've done nearly all the medium ones. Let's see if we can get the respiratory one done as well. Done one. You done a runner, mate? You done a runner? Ah, my fingers. Owie. I thought you made an oath to not use social media. Hey, this doesn't count. It's a chatting service. I barely even use Discord, I'm gonna be honest. I barely even use Discord anyway. If I made an oath not to go on chatting services as well. Actually, I guess Discord does count as a social media, but it's not one of the ones I can doom scroll on. That's the difference. Like, then I wouldn't be able to use WhatsApp, and then it would be a whole thing, you know. Damn. I'm getting aired on WhatsApp now that I think about it. Let me have a look. I got aired. This is so sad. Alright. And oh, what the hell is this? An 18-month-old baby attends the clinic for routine vaccinations. Which vaccine combinations are now due? MMRV. I have no idea which ones I do. I'm very bad with vaccines. What? How the hell am I supposed to remember all those, man? Mr. Sugar, a diabetic male, presents complaining of persistent nausea, fatigue, and dark urine, alongside dull ache and discomfort in the upper side of the abdomen, which is the most likely cause of the specific presentation. Metformin, persistent nausea, fatigue, dark urine, along with a dull ache and discomfort in the upper side of his abdomen. That sounds like flipping bladder cancer. That's pioglitazone then. It counts? No, it doesn't. Then I couldn't use WhatsApp, and WhatsApp I need to use because it's got important messaging. Discord doesn't count. Anyway, I made a clause for Discord anyway because I literally don't even use it now. I used to use it so much when I stream it. Now I literally just like log on once a day and then don't look at it for a while, which is kind of sad to be fair. But you know, there's not. I guess my server's never been that popping. Let's see how far the servers are doing actually. I haven't looked for a while. Yeah, this is doing alright as well. Doing the same, I think, actually, to be honest. Actually, a little bit more than mine. Alright, what is that? I'm not even gonna look at that. Okay, anyways. Let's see, is Claude done? There's a large category with no content authored yet. Yes, mate, that's why I gave it you. Whew. Ooh-wee. I don't know. I just look at my own avatar on the screen. Look weird. Let me see now. File 3, croup, cystic fibrosis, new coughs and colds. Yep. Just hurry up, mate. Hurry up. Man, I need to get to infections and then I want to do cardiovascular system. That would be good. Oh wait, we only got till 9:30, and then I gotta do an exam. So let's hurry up then. Okay, so range of lithium. Lithium ranges 0.421. 0.421 for lithium. Acute mania 0.821 for acute mania, and then 0.4 to 0.8 for maintenance. First line for long-term bipolar, so just for people with bipolar, like Kanye or something. Reduces the suicide risk, always prescribed by the brand. Yeah, carbonate is not equal to citrate. You need to remember that, to be fair. Lithium is the only psychotropic with clear evidence base for reducing suicide risk. Oh. What other psychotropics are there? Is it talking about other antipsychotics or is it talking about other things? Psychotropics. No. Oh, wait. Antipsychotics do count as psychotropics. Yeah, I guess so. They do. It makes sense. It's in the name. So... Okay, what's the lithium carbonate versus citrate? Lithium carbonate versus citrate. I think What? Bro. Come on, man. Stupid AI. 520 milligram of citrate is equivalent to 204 of carbonate. Not good. Citrate's a liquid. Let me edit this one. Citrate equals syrup. Carbonate equals tablets / slow release capsules. Add a point. 520 milligrams of citrate. Okay, that was not what I wanted. Fine. 520 milligram of lithium citrate is equivalent to roughly 204 milligram of lithium carbonate. Cool. Save. Cool. Okay, so basically 0.4 to 1 is the ranges, and acute is 0.8 to 1, so acute mania. And then maintenance 0.4 to 0.8, you want it in between, or maintenance / elderly. 0.4 to 0.8. You wouldn't want it too high, so 0.4 to 0.1, no, 0.4 to 1, and then 0.8 to 1. Okay. I think I'll be fine with this one. I'll just put it there for now. A fine tremor is expected. Okay, let's just check if Claude's done. Claude! Oh, it actually did it. We've got 41 guides for the respiratory category. That is not good. Not good. Take me long enough to do this as I am. What have we got left? We've got the low weight. Let's do vaccines. I am so shy at vaccines. Go now. This. Ooh wee. Okay, I need to hurry up because we need to finish this before 9:30. This is a big topic. Bigger topic. 35 out of 64. That is horrendous rate of conversion. Fine tremor is expected a coarse tremor. So you get tremors. Ataxia. What's ataxia? Lack of voluntary coordination, clumsy gait, confusion. So you get tremor, you get gait, confusion, and then if the levels are above 1.5, that's an emergency, mate. Straight to hospital. Diarrhea, diuretics precipitated. Whoa, wait, what? The 3Ds. Diarrhea, diuretics, and dehydration. So if you're dehydrated, you get it. Diuretics, you get it. Diarrhea, you get it. So yeah, coarse tremor, 1.5. Long-term nephrogenic diabetes. Wait, what? Long-term toxicity. Is that what that means? Nephrogenic diabetes insipidus. Hypothyroidism. Wait, what? Wait, long-term lithium. Wait, what? What Is that high toxicity? Yes, these are two of the most classical endocrine renal complications of long-term lithium therapy. Because lithium is a simple salt filtered entirely by your kidneys, years of therapeutic use alter signaling between renal tubules and thyroid gland. So basically, your thyroid is effed, and your man, that's not good. Wow, in 20 to 40% of patients. Wow. Intracellular pathways, the kidney becomes blind to ADH signals. The kidneys can no longer concentrate urine, resulting in polyuria. So loads of dilute urine. Intense polydipsia. So if you do get it, then do not stop lithium. Amiloride. Potassium sparing diuretic is the first line choice for lithium induced NDI. Wow. I did not know that, man. Amiloride. First line. Can stop lithium accumulate in collecting ducts. And then you also get hypothyroidism. So thiazide is really bad ones. You should not use those. Interesting. So hypothyroidism. Didn't say how it causes hypothyroidism. Oh, it does. Concentrates at levels higher than in the bloodstream. Lithium concentrates. Lithium concentrates. In thyroid, is it? Is that how? Yeah, it actively concentrates in thyroid glands. Start levothyroxine replacement therapy. Levothyroxine replacement therapy as lithium concentrates in thyroid glands and disrupts function. Wow. So lithium toxicity, you get it, basically what happens is you get gait, you get confused. Yeah, just what was the last one? Confusion, tremor. Okay, tremor is a big one I need to remember. Coarse tremor. What the hell is a coarse tremor? Coarse tremor. Of course, it's a slow, large amplitude shaking movement that typically occurs at a frequency of fewer. So it's like really, really slow. So fine hand tremor is very common. Progression to coarse tremor is classic hallmark of lithium toxicity. The tremor spreads from just the fingers to the entire hand and arm. becoming jerky, slow, and large. Jerky, slow, and large. Fine tremor is normal. But coarse tremor is jerky, slow, and large. Q. Save. Okay. The toxicity, you get like a coarse tremor. Amiloride. And what's the other one? Levothyroxine. Okay, let's see how Claude's doing. Claude, you've used 100% of your session limit. Thanks, Claude. Very useful. Alright, let's see. Where were you? Alright, I think that should be enough anyway. We got all the medium topics down. Git add, git commit, new topics, and UI fix, git push. Is it pushed? Okay. Git sync changes. Publish. Should I? Wait, actually. More to import. I need to get them imported first, so we'll do that. Evening Mashy Sob, why is it telling me that? You're not supposed to know. Wait, is this too big? This might be a bit big. There we are. Alright, anyways, why am I doing that? I don't know. Let's go with the next one. Nephrogenic diabetes insipidus. That's very sad, isn't it? Very, very sad moment. Very, very sad. Very, 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 very sad. Very, 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 very sad. Very sad. Very sad. Wait, is desmopressin for nephrogenic or for desmopressin for which diabetes insipidus? For central, okay. Cool. Oh, wait, did it update? Done. All right, republish. Come on. Hurry up then. Publishing takes so long as well. All right, this one I think it's fine. Well, no, actually I don't remember all of these. It needs to be, so if it's more than 1.5, then yeah. Oh, visual disturbance, you get as well. Okay. Needs review. Next. Lithium interactions, ACE, ARBs, NSAIDs. I think I need the top three. Decrease the levels. High sodium antacids. Thiophanine. I need to know theophylline. That's such a dumb drug. I don't like it. I hate it. Theophylline. Neurotoxicity risk with SSRIs, antipsychotics, and carbamazepine. Increased toxicity. Decrease. So increase it is diuretics and that, which makes sense. Decrease it is because, well, wait, why does theophylline decrease it? Theophylline. I still don't know how theophylline works. I need to actually learn about it properly. That's why I hate it, to be honest. It's just so annoying to learn about. Major drug-to-drug interaction where theophylline significantly decreases lithium in the thing is it's highly critical because lithium is narratively blah 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 blah. What is theophylline again? Theophylline bronchodilator acts as a potent adenosine receptor antagonist and a weak phosphodiester. Causes a significant increase in renal blood flow. Ooh. Does that mean it's good for the kidneys? By ramping up kidney filtration, theophylline actively accelerates the clearance of lithium. Well, actually, I don't know if it's good for kidneys because it's kind of so. So is theophylline bad for kidneys? Because bad for kidneys. Yeah, this is a search because it's a adenosine receptor. Now, theophylline is not entirely bad for kidneys. It increases blood flow. However, the relationship is two-way street and dangerous. A standard therapeutic is mild diuretic. It's a mild diuretic. I see. That's why it's bad. Oh. It's a mild diuretic, but it's not a theophylline mild diuretic. If a person takes too much theophylline, getting rhabdomyolysis, AKI. Well, if other diuretics increase toxicity, increase lithium toxicity, how doesn't theophylline? This is my problem. I like to learn how things actually work, and then I think that actually wastes all my time. Sounds completely backward, but the answer comes down to exactly when and how the different diuretic. Oh, yeah, it makes sense. Because kidneys confuse lithium molecules with sodium. A drug that causes the body to lose sodium will accidentally cause lithium toxicity. So lithium works entirely differently, focus on blood flow rather than sodium depletion. I see. This is where theophylline lowers lithium levels while standard water tablets make them skyrocket. Because, bro, I'm doing maintenance on my stuff while you yap and do this. Are you cleaning all your like equipment or something? Your kidneys cannot tell the difference between a lithium ion and a sodium ion. So your kidneys filter a lithium out into the urine, but then the reabsorb 80% of it back into the blood. The kidney always reabsorbs lithium and sodium together. Yeah, because they have the same ion, isn't it? Ionic charge. Right? Do they? Yeah, they do. Sodium flush. The thiazides block sodium from being absorbed, forcing sodium out in your urine. As you flush out sodium, your body becomes mildly dehydrated, so the brain panics and orders kidney to save every grain of sodium. The kidneys can only do this at the very beginning with the proximal tubule, so they aggressively vacuum sodium and lithium up. Interesting. Ooh, theophylline and caffeine called xanthines. They do not. I wonder, wait, does caffeine also do the same thing? Does caffeine also do the same thing then? If it is in the family of theophylline. Yes, caffeine works exactly like theophylline. Caffeine dilates the blood vessels, speeding up the filtration rate, and flushes the lithium straight out your body. The interaction is a major cause of fluctuating lithium levels. Wow, I did not know. So caffeine is a big interaction with lithium. Wait, why isn't this even written it here? This one's a big one. Decrease caffeine. Same family as theophylline, which act as a weak diuretic, forcing more of the which act as a weak diuretic, forcing more of the lithium flushed out. Flushing more lithium out. Body. Okay. And this one works by body panics and tries to reabsorb sodium via the proximal tubule, but reabsorbs lithium too. Cool. Interesting. NSAIDs and diuretics all raise lithium levels. Review before co-prescribing. Neurotoxicity with SSRIs, serotonin syndrome with tramadol. What is this even talking about? Lithium interactions. Decreased levels. Neurotoxicity risk. Oh, it has it with these lot. Okay. Oh, is it because they cause hyponatremia? I don't know. No, that doesn't sound right. Wait, okay. Neurotoxicity risk with SSRIs. I did not know about that one. Antipsychotics as well. Carbamazepine. So lithium can't be really with serotonin syndrome with tramadol and sumatriptan. Wow, just wow. Wait, what's serotonin syndrome presenters again? Shoot. Serotonin syndrome presented as, it's the opposite of it's the opposite of when you stop antipsychotics suddenly. Which one? What's that called again? Oh man, why am I forgetting things? But yes, so it's just like you get tremor and fast heart rate and yeah, that sort of stuff. Bruh, I need to look over that already. Shoot! I'm forgetting it already. Not ready. Neurotoxicity with SSRIs. Antipsychotics. Carbamazepine. Tramadol. Sumatriptan. St. John's wort. Okay. Oh wait, didn't the site update? Let me just make sure. I think it's already updated. Huh. It did. That means I should probably actually save this. So let's see. Did I know this? No, not really. Let me F5. Oh, that was close. What even happened? All right, let's see how CNS is doing. We did 20% of CNS apparently. Well, 20% of it I knew, apparently, which is not great. Let me just have a look about what serotonin syndrome looked like. It would help if my handwriting was good, but it's not, so now it's trash. And now I can't read it, and now I'm crying. Shoot. NMS, neuroleptic malignant syndrome. NMS. Yeah, suddenly stopping dopamine agonists. That's not good. And then you get serotonin syndrome, which is the opposite, which is flu-like. No, wait, no, you don't get flu-like syndrome. You get twitching. Say twitching. You're twitching and reflexive stuff. Reflexive over exaggeration and tachycardia and all that malarkey. Wait, let's have a look at Cappy. Has it done a good job? Start test. Oh, that's an expert. I thought that was a shine. Alright, Cappy, how you doing, mate? Let's see. I've given you a lot more content now with topics. We still got quite a few left, to be fair. CNS. Ginger first in pregnancy, nausea and vomiting, then cyclizine, then ondansetron. Interesting, very interesting. Okay, leave it like that for now. Should just leave it to visible. Okay, yeah, let's have a look. Cappy, can you generate me 4 questions in all topics? Go! Generate. Let's see how it does. Takes about 2 minutes just to generate 4 questions, but here we are. It's fine. It's fine. That's not fine really, but is it? But it's fine. I want to see if it's done a better job now. Wait, where's my phone gone? No, where's my dopamine? Oh, there it is. No, where's my dopamine? Oh man. Oh, generated a question in 30 seconds. Wait, that was 20 seconds apparently. You generated it. That didn't seem like 20 seconds. All right, let's start this quiz. Oh, that doesn't look good. It's messed it up. Okay, well, I'm gonna screenshot this and send it back to Claude because this is unacceptable, to be honest. A 72-year-old man with diabetes collects repeat metformin twice daily. Result from the last week shows, as a dispensing pharmacist, what is the most appropriate action to take? Stop metformin now. Arrange an alternative because metformin at that is not good. Reduce metformin by half an hour. Switch. Yeah, metformin is not good at that dose. At that CRCL. COPD asks for help because she finds her inhalers difficult to use. She has painful osteoarthritis, limiting dexterity, and reports she cannot inhale forcefully for long. Which inhaler type is the most appropriate to recommend for long-term maintenance? 78-year-old man, 78-year-old woman. COPD. Breath actuated. 2-year-old child, itchy red scaling rash around that thing. GPs issued betamethasone. I have no idea, but I'm guessing this one. 82-year-old man with treated. You know, the questions are a lot better though. They actually seem more realistic. With treated hypertension, asks what clinic blood pressure target his GP will aim for. Which of the following is the most appropriate clinic target for someone aged 80 years or older? 80 years or older. Shoot. I think it's 150/90. Yeah, 150/90. Alright, let's finish. Oh, I actually got one wrong. Okay, that's good. That's good. Bro, this is not good that this flipping thing is not working. Wait, what? A PMD with a large volume spacer is preferred option when a patient has poor coordination and limited inspiratory flow because the spacer reduces the need for precise timing and increases lung deposition. DPI requires strong inspiratory, breath actuated and reasonable alternatives is assessed as suitable, but a spacer plus MDI is simply a widely recommended solution for poor coordination dexterity. Really? So breath actuated literally wouldn't help. Nebulizer not routinely recommended, as they are bulky. Poor hand breath coordination. Really? I thought breath actuated would help though. Wait, I'm gonna copy and paste this and ask ChatGPT. Have I made my AI not work? Right. Let's see what it says. Pressurized a metered dose inhaler with a spacer. A spacer reduces the need for precise hand-breath coordination. Why wouldn't breath actuated be better? Be better since she has dexterity problems. Is this just an AI mess up or what? And in this case is that she cannot inhale forcefully. It's a problem of me not being able to read again. Chat. I am so dumb, man. Yeah, I mean, I'm just gonna mark it difficult even though it's not really, but that's so dumb. I just can't read. I just can't read. Alright, I'm gonna get the AI to fix that problem. Let me see if we can fix it. It's not that one. Man, where's the picture? Come on, man. Why is it not giving me the flipping? I hate how you have to go into the thing. So dumb. Screenshots. Open. Sesame. Screenshots. You overdid it. It looks. It doesn't look correct anymore. Okay. Hey, let me just git pull. Git pull, git pull, git pull. Come on. Come on, come on. We are done. Git pull. Oh man, I'm so bored. Oh, what time is it? Nearly 9:30, and we're supposed to start an exam now. Shall I quickly go eat and then start the exam? Half an hour. Wait, what question are we even on? What? Not question. What? How much of this have we done? CNS. Right. There's been a bunch of random things being added. Oh gosh. MS, is that CNS? MS seems more like. MS doesn't seem like CNS. CNS is more musculoskeletal. Right? You're telling me MS comes under CNS? That would be very annoying because I am in between doing lithium monitoring and that lot. ADHD, smoking cessation, alcohol dependence, melatonin. Stupid, I ain't gonna let you get the chance. I need to actually learn to like read the question properly. I just skip over half of it. Yeah, we'll do a question now then. But yeah, I haven't not even went through most of these then. Is CNS, where did I get to? Lithium. Lithium, valproate, topermate. I think I get to this MS. Do I go through all of the MS stuff? There's a lot of MS stuff here. Look at this. No. Alright, chat. I am gonna go eat something and then I'll come back. Man, I'm gonna have to do a flipping exam now. Yeah, that's not fun. Alright. I'll be back. I'll be back. I'll be back.
Oh man, I'm back. Oh man. I ate dinner and other stuff, but I really don't want to come back. I forgot how you do this. Wait, is it this? Oh yeah, I can smile now. I forgot about this. And sadness. No, 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 that's not sad. There we go. Ah, I'm back. Okay, anyways. Alright. Where were we? This is so boring. Beyond belief. Let me see. Did this fix this? I'm just trying to see if the AI fixed the thing. W dinner. I don't know. Eating at 10 p.m. Yeah. Yeah, eating at 10 p.m. Bro, I don't know why it happens in my household, but you know, it happens. Filled it, fixed it, blah blah blah. Fixed. Alright, it says it's fixed it. Let's see if it's fixed it. Git add, git commit. It's a new UI fix for quizzes. Git push. Alright. That's pushed it. Now let me just make sure it actually gets pushed. Replit. What the hell is this on? Okay, Discord. Same day as me. I haven't. Lock in 20th of June. We'll be jumping on Minecraft. Write it in your calendar. Okay. Okay, I guess. Minecraft it is. Wait, what have you sent me? What is this? Hollow body. This is a hollow body. Ooh. Ooh. Oh, and they've got that stick, I don't know what it is, where you can like make the wires like twang or whatever when you're like, I don't know how to explain it. I like that thing. You can make some interesting sounds with that. Alright, let's see. Can I push this? But is that the classic that you're talking about? Hollow. Oh no, that's a hollow body. I'm getting mixed up to be honest, so I don't know. Anyways. Git. Oh no. Git. Sync changes. Confirm. Publish. Republish. Alright, let's see if this updates the site. It's going to take about 10 years just to update. Oh man. If it hasn't fixed it, oh well, who cares? I mean, it did its best. I can't be bothered today. We've got to do that exam as well. I say I've got to do it. It's going to take so long. 2 hours and a half, and it's nearly 12. And I only went through half of this, and then I added a bunch more by accident. At least I know the lithium ranges now. It's 0.4 to 1. And acute mania, it's... Ooh. Is it 0.8 to 1? And then in elderly, it's 0.4 to 0.8. Elderly is 0.4 to 0.8. Yeah, I think. Let's have a look. Did I even write it down on this page? I don't even know what page I wrote it on. Oh man. Where did I even write it? Oh yeah, acute mania 0.8 to 1, and then maintenance dosing is 0.4 to 0.8. Okay. Man, I feel like this stream or these streams are good for training for getting back into stream mode. If I do want to stream again, it would be fun, but I don't know. Yeah, I do want to stream again. I don't know what the hell I'd stream. The thing is, Blox Fruits was so good for like daily streams. I don't know what else would be that good for like daily streams that lots of people enjoy. I can't be bothered to do all that rubbish, like, you know, finding stuff everyone enjoys. That takes so long though. Alright, it's updated. F5. Let's have a look. Cappy, are you updated? Okay. Was my phone vibrating? Wait, is my phone? Where did I put it? No, my dopamine machine. Oh, it's over here. Oh, it's the thing saying it's being published. Ooh, that looks good. Dopamine machine. 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 Oh, start. Start quiz. Bro, it did not fix it. What the hell is this? Oh man. So dumb. Oh well. Diabetes collects. Bro, it made it worse actually, didn't it? Why is this blue background now? Is this what it was before? The old man with type 2 diabetes collects a new prescription for Dr. Flows in when counseling him. Which single point is most important to emphasize? Stop the medication. Bro, it's obviously this one. Why is it so big? Oh man. It's gone back to the thingy. A 67-year-old man comes into the pharmacy with fresh unilateral nosebleeds. Started 5 minutes ago. Not on anticoagulants. Unilateral nosebleed. It has breathed and breathe through the nose until the bleeding stops. Sit upright. Bro, I can't believe it made it worse though. This is actually bad. This actually looks horrible. Sit upright, lean forward, and pinch the soft part of the nostrils. I think it's this one. Contact lens wearer comes to pharmacy complaining of painful red left eye for 18 hours. Was sensitivity to light, blurred vision, noticed a small white spot on the surface of the eye when looking in the mirror. She has removed her lenses. What is the single most appropriate immediate action? You know, these are actually really good questions because I have no idea with these. Blurred vision. I think you have to, if the vision changes, you have to tell them to go to A&E. Helicobacter, amoxicillin plus clarithromycin, simvastatin 40 milligram nightly. You have to stop the statin. Oh wait, do I tell the prescriber? Do I contact the prescriber or supplier and advise? I see that now. I'll just contact them just to be safe. Lean forward to avoid blood pooling aspiration. Apply firm continuous pressure to the soft part of the nostrils, cartilaginous part, for about 10 minutes to compress the bleeding site. Do not tilt the head back, risk of swallowing and aspiration. Do not lie flat and avoid temporary light pinching or stuffing the nostril with tissue, as these are less effective. Seek urgent care if bleeding persists more than 20 minutes. If the patient is unstable or there's trauma or anticoagulation. That one's a good one. Bro, that's so obvious. I don't know why it's done that again. Yeah, that has literally ruined it. Wait, oh, what? Did I not take a picture? Wait, shall I go back and stream and just take the picture from there? Bruh. Yeah, it looked so much better before, bruh. Wait, should I just take a picture now? Let me do another one. I'll take another picture. Okie dokie, okie dokie. Let's start it. Okay, let me just take a screenshot of this now. This is embarrassing. Woman has been started oral for iron deficiency. Without the counseling points is most likely to maximize absorption. Vitamin C rich drink, yeah. Well-controlled epilepsy attends the pharmacy asking about contraception, carbamazepine, highly effective method to avoid pregnancy. Which of the following do you recommend? The IUD. Attends to collect the prescription for allopurinol for gout. Include once daily. What is a single most appropriate action the pharmacist must take? Is that the one that you have to half the dose? I can't remember. Is that azathioprine? With blood count monitoring. Multiple migraine she has had for years. She says she has not seen her GP about migraines recently. What is the single most appropriate action for the pharmacist to take? For typical migraine. over-the-counter supply of oral sumatriptan for typical migraine she has had for years. Hmm. Huh? Uh. Oh. Well, okay. Thanks for the answer. Bruh, this is just so annoying that it just keeps on giving the answer for free. Let me also screenshot this as well. Of course it was. Allopurinol reduces the metabolism of azathioprine. Is azathioprine? Myelosuppressions, FBC monitoring. Myelosuppression. Interesting. All right, let me just tell the AI it did a shite job. Additionally, these answers were handed to me on a silver platter. Pretty much told me the answer by the length and complexity and detail in those answers. Mm-hmm. 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 That is what it used to look like until you changed it, and that is what it is supposed to look like, but you did a terrible job. Used to look like you changed it and made it worse. All right, there you go. I gave it AI such a good telling off. that's to show it who's boss around here. Wait, did I? Was I zoomed in the whole time? That wouldn't have made too much of a difference, right? Okay, anyways. Anyways, we got 1 hour and a half to do my flipping exam that I said I was going to do ages ago. That's so dumb. Alright, let's just do this now. I don't want to do. I only got through half of CNS. The other lithium ones I didn't go through. Okay, let's see. That dude. RPS. Pro Pharma. Green light. We'll do green light. Apparently those are good. No. Wait, are these have answers? Oh, cool. There's answers underneath. Which of the following statements is the most appropriate? Wait, let me just get my phone up. I have to see my flipping money on that. Where's my money? I mean, not my money. Minutes 30. There we are. Start. Gosh, these are so boring. Which of the following statements is most appropriate regarding anticoagulation for the patient? A 77-year-old man has been newly diagnosed with non-valvular atrial fibrillation. He has type 2 diabetes and severe chronic kidney disease. Wait, I need to actually mark these as well. Let me get my piece of paper and put it on. I'll mark it on. Why is it flipping folding all papers? I'll mark it here. Yeah. 77-year-old man, non-valvular, anticoagulation to reduce the stroke risk. DOAC, preference to warfarin. Apixaban twice a day. Direct are contraindicated in severe chronic kidney disease. Roxaban, nope. Warfarin should be used in preference in non-valvular atrial fibrillation. I actually don't remember. I'd say the 2.5 twice daily. Yeah, DOACs are preferred over warfarin in non-valvular AF. So DOACs are preferred, okay. Apixaban is the DOAC of choice and severe renal impairment 15 to 20. Yes, 15 to 29 in it. Apixaban is 15 to 29. Apex Legends 15 to 29 is a reduced one. River is not recommended at this creatinine clearance. Yeah, so that's one mark already. Which of the following is the monitoring requirement for rivastigmine? Ooh, I just did rivastigmine, but I didn't remember anything. Let me think. Rivastigmine is the for dementia, innit? Dementia. Let me try and think. How does it work? Acetylcholine. It's not weight, is it? Urea and electrolytes, I couldn't see you doing that. No blood pressure. I don't remember blood pressure. Full blood, can't remember. Maybe it's urea and electrolytes. D? E, weight. Cholinesterase inhibitors commonly cause GI side effects, leading to weight loss. Ooh. Weight loss. Weight loss. ACH. So I got one wrong already. That's good. It's not. It really isn't. ACH, weight loss. Okay. Which of the following is the most likely reason why? 25 weeks pregnant with gestational diabetes. Oh wow, she's on all this for her diabetes. Measures her blood glucose before breakfast and finds her blood glucose level is low. Having a meal with a delayed spike for dinner. Having been less active than the normal day before. Levomer dose is too high. Levomer dose is too low. She measures the blood glucose before breakfast. Before breakfast. So it's not that one. Having been less active. No. Levomer dose could be too high. Unplanned snack before bed or during the night. Without to make it high. So it's Levomer dose could be too high. C. Okay. So that's 2. Which of the following is the most appropriate monitoring strategy? Moderate to severe Crohn's disease, infliximab. Ooh, infliximab. I don't. Probably like LFTs and everything in it. Check kidney function before sign therapy and monitor blood pressure weekly. Monitor serum electrolytes for infection. Ooh, infection sounds good. Infliximab. No. Pre-treatment screening required. Monitor only for screen for latent tuberculosis. No. Laboratory monitoring. Screen for tuberculosis before starting therapy and assess for infusion reactions during and after each dose. Tuberculosis. I don't know why you'd have to monitor for that. I think B. Oh, it is tuberculosis. Before starting therapy and assess for infusion reactions during anti-TNFA, TNF alpha biologics carry significant risk of TB reactivation and infusion-related reactions. Pre-treatment of TB plus monitoring for infusion reactions is standard practice. You know, I had a kind of idea it might be that one because it looks so specific, but I didn't want to like cheat like that. But maybe I should have. So TNF alpha, TB. I need to go through maybe which of the following medications is most likely to cause this. Is well established on lithium therapy for her latest lithium is 1.2. That's high. So what could it be? Amlodipine, atorvastatin, ibuprofen. It's probably ibuprofen C. That's 3. Which of the following results in diagnostic osteoporosis indicated that pharmacological treatment should be initiated? A 76 a patient who is non-ambulatory and takes daily oral corticosteroids for rheumatoid and has DEXA scan to assess the bone mineral density. What? I don't know what this means. Results is diagnostic of osteoporosis. T score of 2.5. I'm just gonna go with A. C. Who define osteoporosis as a T score of minus 2.5 or lower at the hip or lumbar? So T score of 2.6 of minus 2.6 meets this threshold. I didn't know how to learn that. So DEXA scans. Infliximab. So I've got 3 for 3 right now. I mean 3 versus 3. Which of the following is the most appropriate action? A patient with type 1 diabetes has accidentally injected more than the usual. What they should do: administer a dose of long-acting insulin to correct blood sugar levels. Why? What? Some of these questions are brain dead though. Encourage vigorously to raise blood sugar levels. Give oral glucose, obviously. So D. This is like so dumb. Some of these questions, bro. They're giving me free answers and then, okay, whatever. Which of the following is the most appropriate advice for this patient? A 27-year-old breastfeeding woman has developed lactation mastitis. And is prescribed erythromycin 4 times a day for 14 days. She has a penicillin allergy. Avoid breastfeeding from the breast. Continue breastfeeding. Do not take as this penicillin is antibiotic. What? Wait, what? Express and discard all breast milk while taking erythromycin. Express and discard. Wait, what? Okay. I don't know what lactational mastitis is. Is that a cancer? That is, isn't it? Prescribe. No, mastitis isn't cancer, it's just a infection. Try oral antibiotic. Symptoms are not improved.
despite effective milk removal. Positive. If, treat empirically. If woman is allergic to penicillin, prescribe either erythromycin or clarithromycin 500 milligram twice a day for 10 to 14 days. So wait, what's the problem? Advise. Continue breastfeeding if possible, including from the effective rest. Okay, it says B. That one took me so long. 5 for 3. Okay, we're pulling back, chat. We're pulling back. What is the most suitable treatment for option? Has developed increased sputum purulence. Ooh. Infective exacerbation suspected with the empiric antibiotics prescribed. The patient has penicillin allergy. So they have a penicillin allergy, purulence, and breathlessness. Which of the following is the most appropriate? Oh, shoot, I need to go through my infections, man. Let's see, Doxy. I'm gonna go with Doxy. They have a penicillin allergy, so it has to be Doxy. Oh, cool, ice. I got that one. That's first line alternative in penicillin allergic adults. Which of the following would be the most appropriate for the pharmacist to advise in the first instance? An anxious father phones the pharmacy. His 2-year-old son has developed a pale, non-blanching rash with fever. Non-blanching rash with fever. Refusing food and complaining of a stiff. That's meningitis. Stiff neck. Give an emergency supply. Recommend over-the-counter paracetamol. Refer urgently to A&E. Yes. Okay, we got 7 for 3. Okay. Which of the following counseling points is most appropriate for this patient? Oh man, I hate this, so rubbish. I haven't looked through the SPC. It takes too long. Etrasimod is a selective SN1P receptor modulator approved for ulcerative colitis. 28 steroid appointment is being initiated on it. And breastfeeding. So what's most appropriate for the patient? Should be taken with food, breastfeeding. Taking food to accentuate dose and miss. The next dose should be doubled if you're pregnant. Missed dose. If a dose is missed, should be taken at the next dose should not be doubled, so it's not that one. Should be taken with food. Doesn't say anything about that. Once daily is recommended to resume treatment with food if there's interruption. Should be taken with food for the first 3 days. Dose interruption, kind of? I don't know. That one kind of makes sense. Okay, and then breastfeeding. Breastfeeding. Breastfeeding and pregnancy. Where is that? Breastfeeding. Or considered pregnancy. Breastfeeding is unknown whether it does it in rats, whatever. Should not be used during breastfeeding. Okay, should be stopped at least 14 days before pregnancy. It should be immediately discontinued. So what does it say? You should know, stop before, no. I think it should be the B. Yes. Okay, 3. I've got 8 for 3. Okay, we're doing okay, chat. Which of the following monitoring requirements is appropriate for this patient? Sulfasalazine. Whole blood count and renal function. Ooh. For every 2 weeks for the first 3 months, then at least every 2 weeks. Every 2 weeks until stable for 6 weeks. That sounds right. Then monthly for 3 months. Then I think it might be B. 2 weeks until stable for 6 weeks. then monthly for 3 months, then at least every 12 weeks thereafter. Wait, what? 12 weeks thereafter. Isn't 12 weeks 3 months anyway? Oh, yeah, 3 monthly. Wait, what's the difference between this one and this one? That looks like the same answer. Full blood count liver function test and renal function every 2 weeks until dose stable for 6 weeks, then monthly for 3 months, then liver function test monthly for the 12 months, then at least every 12 weeks. Every 12 weeks. I think it might be B. Yeah, I got B right, but I don't know why there's 2 B's. Okay, we're doing okay, chat. We're doing okay. 13. Which of the following is the most appropriate counseling point to support adherence and optimize treatment? Counseling point. Stage 4 CKD, heart failure, fatigue and pallor, iron deficiency anemia confirmed, oral ferrous sulfate prescribed. Can be chewed? I don't think so. If you stop nausea, stop to prevent. No, take on an empty stomach. Take with food. Was it with food? I think it was with food. Was it? It must be. E. D. On an empty stomach. It's reduced by food. But I thought not all food. That's what I thought. Okay, that's kind of dumb. That I got that wrong, to be honest. That's kind of dumb. How did I get that wrong? That's so dumb. That is so dumb. I shouldn't have got that wrong. We're 9 for 4. Which of the following actions is the most appropriate for this patient? A 50-year-old man on tacrolimus. Ooh. Kidney transplant. Target trough 5 to 10. Latest level is 10. It is 12. Trough level. Reduce the dose for 25. Switch to cyclosporin. Withhold tacrolimus for 24 hours, then resume at its current dose. I think reduce by 25, what would that be? 25 would be divided by 4, 3, that would be 9. I think reduce the dose. See? Yes. We got 10 for 4. Which of the following is the most appropriate action? Atopic eczema presents with worsening itchy rash. Currently applying emollient twice daily. Advise continue emollient twice daily and monitor for improvement. Recommend obtaining a prescription. He's got eczema in it. Obtain a prescription of clobetasol. Yeah. It's worsening, isn't it? Pediatric dermatologist, sell it. I think pediatric dermatologist, if it's worsening, around elbows and knees, I think it's better for the... Okay, I got that wrong. Apparently you just sell them hydrocortisone and advise using once or twice daily for up to 7 days. I mean, if it's getting worse, it shouldn't be getting worse with emollient. It should just be staying around the same, right? Which of the following is the most appropriate management option for her ankle edema? But guys, I'm kind of losing now. I've got 5 out of 10. I mean, I've got 5 and 10. A 66-year-old woman with bilateral ankle edema, ankle swelling, hypertension, amlodipine. She's on amlodipine. Switch to an ACE inhibitor, I would say. 66-year-old woman. Yeah, that's some amlodipine. So that's one more. Which of the following is the most appropriate action for this patient? Gritty eyes, yellow discharge, no pain, photophobia, no contact lenses. Treatment is only necessary if persists for 7 days. I'm not actually sure. Cell chloramphenicol,
Should I just sell him chloramphenicol? I'll just sell him chloramphenicol. C. Ointment. Ointment, they can't drive it, but oh yeah, C. First line treatment. Okay, well, 12. It is C. What is the most appropriate in immediate management? Second cycle of etoposide and cisplatin. Oh gosh. Sore throat, rigor. Discharge with antibiotics and check temperature. Oh, no. That's almost looking like. Start oral colomoxiclav and review in 24 hours. Wait for blood culture results before starting treatment. I think immediately just start him on IV. A. Rigor. Fever. Yeah, he needs to. A. Neutropenic sepsis. Before culture results. They should also say that they need to take a sample first though, but okay. So I've got 13 now and 5 wrong. Not the best. How many vials of powder or concentrate for solution for infusion are required to prepare each infusion for this patient? What? Oh, not another one of these. I hate these, man. Powder for concentrate. Alpha glucose updated body weight is 22 kilograms. They got 22 kilograms. Prepare for infusion. 8-year-old child, Pompe disease. Pompe disease, 22 kilogram. Postology. Eight-year-old child. Is there anything about children? No. Recommended is 20 times by, well, 20. 22 times by 20. So wherever is my calculator, that'd be helpful. I can't even see it, so that's great. Oh, it's underneath here. 20 times by 22 is 440 anyway. I don't need a dumb calculator. Oh, man. Oh, I need it now actually. 440 milligrams, and then divide it by how many? How much do the vials come in? Oh wait, no, do I? 100 milligram powder for concentrate. 440. That'd be 5 vials. I'm just gonna guess. I can't be all. Oh wait, actually, there's a thing here. Do I need to do all this? It's gonna waste so much time. Yeah, I'm not gonna do it all. I think it's 5 vials. If it's 100 milligram per thingy, I'm gonna go with 5. Oh, let's go. We're doing okay, chat. We're doing okay. 14 for 5 wrong. Which of the following is the most appropriate advice for this patient? Nasal congestion, facial strain, thick yellow nasal discharge, recent common cold. Otherwise takes Ramipril 5 milligram daily. Self-care such as rest. Facial pain, nasal congestion, 3 days. Refer the GP for antibiotic. I don't think so. So I'm bad at these. She's well. She got facial pain, nasal congestion. I say the fluticasone was for the pregnant woman for. I forgot wait, fluticasone pregnancy. What did they recommend it for? Severe allergy stuff. But I think the pseudoephedrine maybe. Oh, just self-limiting. Acute is self-limiting viral. I was gonna say that, but okay, whatever. I got that wrong. No. Which of the following infections is not preventable through vaccination? Okay, here we go. Chickenpox caused by the varicella virus, malaria.
Get malaria and stuff, right? Vaccination. Isn't that that's not a virus? That's a bacteria. You're gonna get bacteria. Okay, I'm gonna go see. But you can get a pneumococcal disease. What? There's a strep one. Strep vaccine. Whoa, there is. Wait, how the hell do I not know this? Wait, there are no licensed vaccine available for Group A or Group B strep. Okay, whatever, man. I don't even know what it's talking about. Malaria. There's no routinely available vaccine. They just do chemoprophylaxis. Oh man, I'm getting these wrong now. But I knew that as well. I don't know why I did. Okay, whatever. Which of the following chemotherapy agents is most strongly associated with this adverse effect? He's got worsening, numbing, toning, difficulty buttoning up his shirt. Not methotrexate. I'm ahead of that. Doxorubicin now. Fluorouracil? What? That doesn't sound right. It's probably cyclophosphamide. Or the I don't know. It's oxaflatoine. I should have done that one because I've never heard of it before. Strongly associated with cumulative dose-dependent peripheral sensory in colorectal. Okay, I'm getting every single one wrong now. This is not bad. Good. I've got 8 and 14. Which of the following is most appropriate for this man's advice? Metastatic lung cancer, morphine twice daily. Finds him difficult to wake. Conscious but very drowsy. Pinpoint. Oh, he's got too much morphine. Advisor to increase drowsiness. No. Reduce the dose. Seek urgent medical assistance, I think. D. Yeah, pinpoint. As soon as you see the pinpoint pupils, not good. Which of the following is most legally time critical in clinical practice? Apixaban for afibrillation, clozapine for schizo, Cocarel double definitely, levetiracetam probably most definitely. Time critical. Apixaban for stroke, probably. Clozapine as well, probably methotrexate, right? No, but methotrexate you can't just stop. The ones I don't know about is apixaban, clozapine, and methotrexate. Maybe the apixaban. Apixaban A. E. Weekly. Oh, flipping heck, man. It's weekly. Why don't I just think a bit longer? Unlike anti-AF. Antipsychotics. When missed delays can cause clinical direct. How the hell am I getting simple ass ones wrong? I've got like 1, 2, like 3 maybe easy ones wrong, man. Which of the following is the most appropriate immediate action? I can't be asked with these ones. Every reports burning extravasation. Yeah. What do you do with soft tissue disorder? Extravasation prevention management. To be stopped. Corticosteroids are usually given to treat inflammation. Okay, I think A then. And refer to plastic surgery. Burning and swelling. I guess I'll just go with the systemic corticosteroids A. E. What? Where did you say that? Oh man, how the hell can I not read? That's another one I could have easily got right, man.
What would be the most appropriate evidence-based management strategy? A new mother asking for advice, baby inconsolably crying for the past few weeks, more than 3 hours a day. Wow. Bathing the infant in a warm bath, modify the mother's diet, supply lactase, simmeticone, supply probiotic supplements. More than 3 hours a day. I have no flipping clue. Maybe the lactase, co-leaf. Bathing the infant in a warm bath. Infantile colic is managed with reassurance and supportive measures. Are not routinely recommended due to limited evidence. Warm bath, but that's more than 3 hours a day. So every time he's crying, just a warm bath every flipping time. Okay. I don't know how I'm supposed to know that. Which of the following drugs would be the most appropriate option for this patient? So I wonder if all the examiners, when they're making up these exams, are they going to be looking at all these questions and not picking questions like these again? Because everyone who's done these exams will know all the answers now. So I don't know. Which of the following drugs would be the most appropriate for this patient? Persistent insomnia related to work stress. Tried sleep hygiene without success. Short course of medication being considered. He's got 45 persistent insomnia related to work stress. Try sleep hygiene. Short course of medication being considered. If it's a short course, maybe the Zopiclone. But I don't know if that's first line. All of these seem kind of... Diazepam seems too much. I'm going to go with Zopiclone. E. Okay, few is short term, management of severe insomnia with the lowest effective dose of non-thingy for the shortest man. Okay, luckily that was right. What is the following is the best explanation for the patient's high INR? Ooh, meconazole. Meconazole in... Wait, what is meconazole? Scrap GPS. No, it's a sickface.com, which is a inhibitor. It inhibits hepatic metabolism. C. Let's go. Which of the following is the most appropriate additional drug treatment for this patient? Metformin. So DAPA next in it. Yes. Which of the following most appropriate for this patient? A 19-year-old, cold air, mild asthma diagnosed. Mild asthma, you do... Where is it? Fluticasone and budesonide and formoterol. 1 puff when required. B. Yes. Stable monotherapy is no longer recommended. Ooh, I didn't look at his age. Imagine that. That would have been bad. 30. 31. With recurrent lower UTIs. Behavioral and hygiene measures ineffective. Estradiol. Ooh. Estral cream. I reckon it's the estral cream. 68 postmenopausal. I do think it's the estral cream. You can't take nitrofurantoin long term. Estradiol is another option, but I don't think you take that if you're over 65 probably. Yes, estral cream. For postmenopausal women when behavior measures are ineffective, consider antibiotic prophylaxis. Before considering, do that vaginal estrogen. So that's C, done. 31C. Which of the following is the least likely to be congenital malformations when taken during pregnancy? Isotrexate, no. Levothyroxine. Methotrexate, yes. Rampil, yes. I think it's levothyroxine B.
Okay, we're pulling it back, chat. We're pulling it back. I'm getting all these right. Which of the following is the most appropriate action after a diagnosis of pancreatitis? Wegovy. Oh gosh. Push it on. Yeah, that causes it. Discontinue semaglutide permanently and do not restart. Reduce it to a maximum. Switch to an alternative. Withhold during the admission. Restart. Withhold during. I think you just stop it and do not restart in it. But although, is there any withdrawal symptoms? I don't know. A. Oh wait, does this tell you the answer? I kind of can't be bothered to look through it though. Contraindications. No, it's not a contraindication. Acute pancreatitis has not been studied and should not be used. It has been reported. Patient should be informed. It should be advised. Semaglutide should be discontinued. Should not be restarted. Okay. It's a do not restart. I don't even need to really look at the resource for that one. Which of the following is the most appropriate direction for this patient? Missed yellow tablet yesterday, and it's a combined oral contraceptive. What even is that? Is that desogestrel? No, the tablets are missed. What even is this? It's estradiol. So she missed yesterday's tablet. Next tablet is due now. Pathology. How to start. I think I just saw it, but I can't see where it was. I swear, even though I have a lot of music stuff already, I would still want more. What more do you need, bro? Oh, you just get a trumpet. Oh, that makes me want to listen to Flippin'. What's his name? Peso Pluma. A Flippin' song. I haven't listened to it for ages. Actually, to be fair, I feel like piano would be a good one. But that's expensive. There's a keyboard then. I need everything. Okay. Missed can be disregarded, however they should be. It's got to avoid. If a woman's less than 12 hours, no, I think it's more than 12 hours. Maybe reduced. So it's 14 days now. Day 8 to 17. Take the tablet, missed immediately. Take the next time as usual. Take today's dose and continue now and continue use. Discard it now. Do not take the missed tablet and discard the current. I think it's A in it. Use backup for 9 days. It's A. What? E? Take 2 tablets now. That doesn't say. This one says take today's dose now and continue taking another dose. I don't. Okay, whatever. I need everything. Oh, bro, what? You don't need everything. You don't need every single thing. What else is there? A good one. I see those electronic weird ones. It's just like a little keypad. Those are interesting. Oh, you should get what's it called? I mean, you can pirate it, but yeah, I didn't tell you that. What's it called? That mango? What's it called? It looks like a mango. That software. Fruity Loops or something? Fruit Loops. I would really love a Les Paul, bro. Isn't that like a really expensive guitar? Les Paul. Yeah. Les Paul. Bro, why is it thousands? What? Oh my gosh.
Anyways, somehow I got the easy question wrong, but that's okay. It's not okay really. It's not okay at all. What dose of aprepitant oral suspension should be administered on the first day of chemo? Depends where you get it and what kind. Yeah. Bro, I don't. Yeah, I would. You've got enough guitars. What dose of aprepitant oral suspension should be administered on the first day of chemotherapy? 7-year-old, 21 kilogram, very high emetic risk. Very high emetic risk. 7-year-old, 21 kilogram. See the table. 21 kilogram. 7-year-old, day 1, 75. 75? Oh, it's in 75 in that. What is that? 75 divided by 125. 75 divided by 125 is 3 over 5, which is 0.6. 0.6 times by 5 is 0.6 times by 5. What is that? Oh man, I can't be bothered. It's 0.5 times by 6. 3 mil. 3 milliliters. D. Let's go. Free mark. Why didn't I just use my calculator? It was right there. Anyways, which of the following is the most appropriate pharmacological management if a child has a prolonged febrile seizure at home? So 3-year-old generalized tonic-clonic with fever lasting 80 minutes. Isn't it over 5 minutes? You're supposed to do more. So it's at home, febrile. Ooh. Erectile diazepam. No treatment. Now drowsy but recovering. No focal signs. Another prolonged febrile seizure. Give rectal diazepam then, B. But wow. So 3-year-old, you have to literally shove diazepam. That's very sad. Rectal diazepam. Who would have known? Which of the following is the most appropriate recommendation? 4-year-old with vomiting and watery diarrhea for 24 hours, sips of water only. What? 4-year-old boy with vomiting and watery diarrhea for 24 hours, sips of water only. That's all they've had. Ibuprofen doesn't seem very good. Loperamide is an option, I guess. I think oral rehydration salt. Why have they only had sips of water though? Well, if they're vomiting as well, I think the rehydration, rehydration is the mainstay of gastroenteritis management. Loperamide antiemetics are not recommended in children. Really? Antiemetic is not recommended in children. Not recommended in children. Well, at least I got that right, but I don't know how. What is the minimum period a CD register must be kept? 2 years, isn't it? 2 years from the date of the last entry. C. Come on, lad. 39. Which of the following is the most appropriate next step in long-term COPD management? He has stable COPD. Oh gosh, I'm really bad at COPD stuff. I haven't went through it yet. Resistant breathless, despite salbutamol PRN. No asthma history. 2 exacerbations in the last year requiring antibiotics and steroids. Persistent breathlessness. Salbutamol PRN. No asthma history. 2 exacerbations in the last year. I think he needs some triple inhaler. Well, do you need triple straight away? I don't know. Is this... I'm actually not sure. Long-acting beta agonist, so like a formoterol. No, I don't think so. I think it might be the 3 triple inhaler, right? But that seems like too much. Long-acting muscarinic. What's that? Like a tiotropium and that. Yeah, I think it might be D. C. So it is that one. ICS is reserved for those with asthmatic features or repeated exacerbations on dual therapy. So, okay, that's easy to remember though now. At least I know it now, even though I didn't even go through it. So SABA, then LAMA and LABA, then an ICS LAMA LABA. You probably know what the hell is this guy on about. Yeah, I don't know. So SABA, then it goes to LAMA LABA. Then it goes to ICS LAMA LABA. For COPD. Cool, I got that wrong though. So not cool. Which of the following is the most appropriate to initiate? Stage 1 hypertension, no organ damage, lifestyle adjustments, insufficient, hypertension, type 2 diabetes, 59-year-old. Seems just look like amlodipine in it, really. Type 2 diabetes. Is diabetes you go for the other one? No, I don't think so. Is amlodipine in it? Fudge. How am I not remember this? Let me just get up the guidelines. Bro, this is so simple. How have I messed that up? Hypertension. Treatment flowchart. Hypertension. Hypertension without type 2. Oh man, I always get this wrong way around. Hypertension with type 2 diabetes, then you go ACE and ARB. Bro, I kind of knew the like background of it as well. I was like, surely, oh my days, man. So it's type 2 diabetes, you would say start ACE and ARB. Hypertension, type 2 diabetes. ACE and ARB. Age under 55 and not of Black, African, or African Caribbean. Family origin. Man, that's so simple as well. I don't know how I've got that wrong. So dumb. Which of the following treatment? Let me just put that on the marker list that says I could have got that mark if I actually tried. Which of the following treatments is used to shift potassium into the cells as part of acute management of hyperkalemia? Shift potassium into cells. So that sounds like... Oh. I thought that was insulin. Which of the following treatments is used to shift it into salbutamol? E. Let's go. What do these most likely indicate? Euthyroid, wait, what? Weight loss, palpitations, heat intolerance. TSH is very low. 3 to 4 is high. So that is hyperthyroidism. B. Wait, weight loss? Yeah, hyperthyroidism. B. What's subclinical though? I don't know what that is. B. Yeah, what's subclinical hyperthyroidism? Search. Is by where thyroid is levels are low or indetectable, but T4 remains strictly normal. Then what's hypo? Mild. So TSH, but normal T4. Okay. Well, at least I got that right.
Chat, man. Which opioid is most appropriate to initiate for this patient's management? Pain management. Advanced colorectal cancer. Like CKD, persistent pain despite paracetamol. That does definitely need some more help. I'll probably go with morphine at that point because that seems like a lot. Codeine is not gonna. Oh, colorectal cancer. Could you not? Does that not cause problems though? I'm just gonna go morphine anyway. C, D, oxycodone. In EGFR. Oh man, EGFR. I didn't even look at that. EGFR less than 30. EGFR less than 30. Morphine bad. Morphine, codeine avoid. Oxycodone preferred with caution. Oxycodone. I didn't even see his EGFR. Why did I not see that? Oxycodone. Fent. Fent. He gave and buprenorphine. I wonder in America, do they give fentanyl in the hospitals? Because they have a crisis over there, don't they? With that, I think they have a crisis here at this point. But the zombie stuff over there is kind of crazy. Which of the following concerns from the mother would most clearly warrant a urgent reassessment for the child? What mother returns today worried? Urgent assessment. She's on Amox with acute otitis media because an irritable occasion spits out part of her amoxicillin dose. That doesn't really. Cries inconsolably and is constantly pulling at her right ear. Develops mild diarrhea after starting the. Ooh, mild diarrhea. That could be C. diff. Drinking adequate fluids but not eating quantity. Reluctant to start amoxicillin because of bitter taste. So I think it might be either B or C, but I think it's C. B. Oh, okay. The diarrhea after starting it doesn't matter. Man. So I guess that was just a side effect in it. I thought maybe she had C. diff. Mild diarrhea doesn't matter then, I guess. Which of the following drugs would be suitable first line pharmacological treatment option for this child's GI symptoms? Frequent painful bowel movements and occasional soiling. Painful bowel movements. Infrequent. Probably some Macrogol, right? Yeah, I'll go with Macrogol because that does not sound right. C. I mean, yeah, D. I meant to say D because they're Macrogol. For which of his irregular medications would increase the risk of pulmonary aspiration? Wait, what's tirzepatide again? Oh yeah, that's Mounjaro. Not Mounjaro. Not Adcal. Cocodil, maybe. Levothyroxine, maybe sumatriptan. I think the cocodamol. What does sumatriptan got to do with anything? Oh wait, aspiration risk. Pulmonary. Tirzepatide motility. Maybe the tirzepatide, but weekly. I'm gonna go with tirzepatide just because of the pharmacodynamics I can think of. E. Yeah, it is E. Increasing perioperative risk. Bro, that was some knowledge there. I didn't even learn that one, but I just figured it out through knowledge. Yeah, receptor agonist, delay gastric emptying. So you have to withhold those. What advice should be given regarding contraceptive pill? On desogestrel, due to start tirzepatide. For weight loss, continue as usual. Continue as usual, but also use additional non-oral contraception. Do not take it at the same time as tirzepatide. Stop the contraceptive. Ooh, wait. Delays gastric emptying. Desogestrel. Stop the contraceptive, especially during the 4 weeks of starting and after any dose increase. Stop taking the contraceptive pill. Why have they made a question about it though? If you don't have to continue as usual. I thought you'd continue as usual because there's a actually no. Could be overdosing on it. That would cause you to overdose, right? Continue as usual, but do not take it at the same time as tirzepatide. Stop the contraceptive, especially during the first 4 weeks. Stop taking the contraceptive pill. I'm not sure. I'm gonna go with I'll just go with D. I don't know. It's B. Continue as usual, but also use an additional non-oral contraceptive. Tirzepatide may reduce oral contraceptive efficacy. I thought it'd make it overdose, right? Oh no, delay absorption. Or gastric motility will decrease it, so that makes it sound like it'll stay in the gut longer, right? Oh man. Okay, I got that wrong. I need to get to 70%. I need at least 70, and this is not looking good so far. Which of his regular medicines will be need to held prior to starting infusion? Why am I looking at the answer? Oh my days, I looked at the answer for this one. I don't know, I just clicked straight on the answer. I was thinking about something else and I just click on the answer. I'm gonna try and work it out. How they got this? So vascular warts, severe chronic lower limb ischemia, iloprost infusion. This is all his medication. I don't know what iloprost is. If you're on medication for high blood pressure, these medications should be stopped for the days. High blood pressure medications, Ramipril. Okay, I would have got that. I would have got that. All right. So don't say I got that wrong. Ah, man. The patient weighs 120 kilograms, and assuming the titration is tolerated at 30-minute check, what is the total amount of iloprost after 6 hours? Oh man, what do I have to go back on that stupid thing again? Iloprost, 120 kilograms, 30-minute check, what is the total amount after 6 hours? Total amount of iloprost administered after 6 hours. 6 hours. Where does it even say the dosing? Huh? Oh, here it is. I was like trying to find the flipping. There's a formula right here. Patient's weight. Patient weights times by 0.06. So what is their weight? 120 kilograms.
Right, 120. Okay, that's quite hefty. 7.2. Do not exceed 6 mil per hour. Okay, so I guess 6 mil per hour then is the max. So 6 mil. And he's doing it for 6 hours. Is it titration? I'm just going to do... Oh, here it is the IV flush. Should I just not be bothered and just do whatever I want? Micrograms, so it's 2 micrograms per 1 mil in diluted solution. So it's 2 times by 6. That's a 6 mil. And then over 6 hours, you'll be getting 72. Okay, I got that completely wrong then. Why is there a maths question in here, man? Dose rate via... What? Okay, let's do the 5 mil one. 10 times by 5. That's... No. 2 times by 5 times by 6, 60. No. Do I have to use the instructions? Start at 1 mil for 30 minutes. Oh, my days. Let me just calculate it then. This is so boring. 2 per mil. Start 1 mil per hour for 30 minutes. So he's only going to have 0.5 per mil. So he's only going to have 1 microgram at the start. Plus pulse check. If tolerated, continue to 1 mil per hour every 30 minutes until the optimum tolerated rate is. So you have to increase by 1 mil. So okay, so oh my days, this is a long one to add up. So 30 minutes, and then at 30 minutes again, it's gonna be up to. So they're gonna increase it to 1.5 mil. Wait. They're gonna increase it, so they're gonna increase it 2 mil. So they're gonna increase by 2 micrograms. Then another 30 is passed. Oh my days, this is so annoying to do. Wait, so that's 1 mil. That's 2 mil. Then they're gonna increase it to 3 mil for another half an hour. So 3 mil would be 3 mcg. 4 mil, 5 mil, 6 mil, 30, 30. So that's 4 mcg, 5 mcg, 6 mcg. So now, how long has that passed? So that's 1, 2, 3 hours, and then for the rest of 3 hours, 3 times by 12. Equals 36 plus all of that. 1 plus 2 plus 3 plus 4 plus 5 plus 6. 21 plus 36 equals 57. What a waste of time. B. Stupid. 57 micrograms. 50. What is the likely cause of her admission? 4-year-old presents with nausea, vomiting, abdominal pain, sweet to smell breath. Ooh, she's on DAPA, sweet to smell breath, diabetic ketoacidosis. C. Which of the following must be included on dispensing label for veterinary medicinal product? the words for animal treatment only. E. Ooh, I'm nearly got another 5. What is the most appropriate alternative for the patient imperative operative area? Oh my days, man. I don't want to do this. Please don't be another one. Oh my days, I hate these questions so much. I actually hate these questions so much. Fine. Fine, fine, fine. If that's how you want to play. Pixel. I don't actually know what that is though. Base. Oh, Pixel. Is that just a quality of life, dopamine? Dopamine antagonist. No, dopamine agonist. Dopamine agonist. I think. I don't know. All right, let's see. Is the patient on levodopa? Are they on levodopa? No. Okay. Adjusted total levodopa dose equals 0 if not on levodopa. Push patient on dopamine agonist. Yes. What is the LD equivalent? I don't know if it's a dopamine agonist. I think that is dopamine agonist. I'm pretty sure. Prime pixel. What is the LD equivalent factor? LEF. It's 100. 100. Bro. It says it's 100, right? But it doesn't tell us. But they're taking that 3 times a day, so I don't know if you have to times it by 3 times. I'm just gonna put 100 then, because that's the LEF. 100 equivalent total levodopa dose. Equals hundred, right? So I think it's 100 mg. And then 100 mg. Adjust LEDD to reduce side effects. So times it by 0.5. That would be 55 milligrams. Then if it's a less than 350, then you prescribe rotigotine. Then you do adjusted 55 divided by 20. So what would that be? 55 divided by 20, 2.75. Round up to nearest 2 milligram up to 16 milligram. Up round around 2 nearest. So that would be 2 milligram patch on it. All right, let's see. B. E. See, how have I got that then? Is it because he's taking 3 times a day? Oh, he's on Cinemat. I can't read. 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 I actually don't know. Okay, let me just add it on then. So what would that be? 7. So COMT inhibitor. They're on a COMT inhibitor as well. Bro, I saw they're on a COMT inhibitor, but I didn't see that they're on Cinemet. Am I dumb? Yes. So let's see. The 100 milligram QDS, 400 milligram, 400 milligram per 400 times by 1.3, 520, 520 plus by 100, 620, 620 times by 0.55, 341 divided by 20, 17.5. Yeah, I would have got that as well. I just can't read. That's so annoying. That's an easy mark, and I just blew it. So I feel like the majority of these marks I lose is just like me just not reading. For some reason. Post bowel resection with stoma, loperamide, but stoma output is high. Continue with current prescription. The maximum dose that prescribed 16. Increase the dose of loperamide as high dose can be used off label. I'll say increase it, right? Ooh. Because higher output stomas, I think you can increase the dose. I'm just gonna go with C. Aye, that was straight off the dome. I didn't even look at the flipping guidance. Come on. See, I can do like harder questions. I can't do easy questions. What is the point? Literally, what's the point? What's the point? I should just focus on just figuring out how to do easy questions. Which of the following would not be appropriate for this patient? Fecal impaction, chronic pain. Oh my gosh, they got so much stuff here. Citalopram, glucocephral, diclofenac, morphine. Oh my gosh, omeprazole, peanut allergy. Ooh, peanut allergy. I think you can't have arachis oil with peanut allergy, is that so? I can't remember. Enamel suppository proposed. Fecal impaction. I think you can use glycerol suppository. I'm just gonna go with that C. A. Okay, never mind. Not appropriate. I can't read. I can't read. I can't read. Bro, I literally said arachis oil is peanut allergy as well. I literally said that. I just did not read the flipping question that says not. Chat, I don't. What am I even doing in my life, man? I'm just. That's so annoying, man. I literally can't read, bro. That was the easy mark. Wait, let me just place those last two on the marks that I could have easily got if I actually read the question. What must be in place before being able to dispense this? First, with a prescription for sodium valproate for epilepsy, they need a pregnancy prevention program. Yeah, easy mark. E. Which of the following doses are most appropriate for this patient? What? Trust policy is 0.5 units per kilogram, so that's 42 kilograms. 42 estimated total dose divided across the day per usual frequency. That's a Lantus Solar Star. So 42 units. Lantus Solar Star. $42 units once daily. No, rapid, no Lantus. 42 units. 21 units with 21 units. 21 units, 7 days TDS. Okay, yeah, it's B. Bro, all of these are so weird. I was gonna say that looked so weird. 57. 58. Which of the following antipsychotics is associated with highest risk of weight gain? Ooh, it's olanzapine. What was the other one? Highest risk. And aripiprazole is the least, and olanzapine is one of the highest. With, was it clozapine as well? Along with clozapine. Come on, this knowledge just is escaping my head. What is the maximum time frame should be started within? Receives a needle stick injury from a HIV positive patient. Oh, poor nurse, man.
I just feel sorry for the nurse, although this doesn't even exist. What is the maximum time frame that deposit post exposure prophylaxis should be started within? Would they just get HIV straight away then? Within the least amount of time. Maximum time frame. I'd say within 12 hours, 72 hours. Not recommended beyond 72 hours. Okay. So they live for 72 hours before literally life gets turned upside down. What dose of Comoxiclav would you recommend? Where's Comoxiclav surgical prophylaxis? 24-year-old. It's 57 kilograms. Post-surgery prophylaxis. Posology. Adults. Wait, how much does she weigh? 57. For procedures less than 1 hour in duration, the recommended dose is this. Wait, what? How long is a procedure? Oh man, there's loads of options. I see random answers, but I'm gonna pick B. I'm not gonna read it, but I think it's B. Oh, it's E. Why didn't I just read it? Yeah, I'm gonna read it now. Why did it? Wait, did she have dialysis? Oh, she's receiving hemodialysis. I didn't read that, man. Oh, man. I can't read, 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 I can't read. That's another mark I lost just because I couldn't be bothered to read. Which is the most appropriate counseling point. But this is kind of dangerous. How many marks I've lost from not reading. Oh my gosh, which is the most appropriate counseling point? Hypoglycemia, recurrent after switch from Humulin M3 to Humalog Mix 25. Eject immediately after food. Reduce the dose by half because it is more potent. Shake the cartridge, switch back to an human insulin pen. It doesn't mean Humulin. Why is he even switched? Before meals, recurrent hypoglycemia. Reduce the dose. I think I'll just switch it back if he's got flipping so much. But then what? He's just using it wrong then probably. Reduce the dose by half. Shake the cartridge before use. Oh. Maybe it's that one, D. Maybe he's not shaking it. Oh, never mind. B, inject immediately after food. Wait, what? B, inject immediately after food. Contains rapid antigen Lispro and should be injected. But I don't know what he's doing right now. How am I supposed to know? So how am I supposed to advise him if I don't know? Administered immediately after food, giving it 30 to 45 minutes before meal. Risks hypoglycemia. I was thinking that, but then... Okay, whatever. Wait, do you have to shake these?
You should not shake. Shaking can create bubbles and lead to inaccurate. You should mix the insulin thoroughly but gently. Roll it between your palms. So you're not supposed to actually shake them. You're supposed to roll them, invert it up and down. Whatever, man. Which of the following is most likely to provoke symptoms of GORD? Alendronic acid, probably. Yeah, alendronic acid. Causes heartburn. Right? Yeah. 63. Which of the following details is not legally required when making the entry in the controlled drugs register? Morphine. Identity confirm. Entry made in the CD register. The proof of identity. Quantity supplied. Name and address of the person collecting the prescription. I actually don't know. I think it's a name and address of the person. That doesn't make any sense though. Yeah, name and address of the person is not a legal requirement. But that doesn't make any sense. Oh well. Before which of the following statements regarding Mr. T's treatment is incorrect? Oh my days, what's all this? Prescribed for active rheumatoid arthritis, 75 times by 5.5, only 200 mg. Available, 75 times 5.5 is 412.5, so that's like 2 tablets. 2 tablets. Mr. T should be starting on dose of 0.3. Should we ask for any visual impairment? Oh, I remember that. And the near visual acuity of both eyes should be recorded. Was that treatment? Wait, is incorrect. Based on his A, right? 0.3 grams daily. What does that mean? Before starting treatment. Renal and liver function during treatment. The disease modified. So I think it's 0.3 is A. Bro, that was Bro, I knew all the other ones. You should have given me a harder one. Which of the following is the most likely adverse effect? Long-term or repeated courses of systemic corticosteroids. Ooh. Altered skin. Anorexia. Hemolytic anemia. Psychiatric reactions. No. Pulmonary fibrosis. That sounds like COPD. Maybe altered skin pigment and hemolytic anemia. I'm gonna go with altered skin pigment. Systemic though. Can't be anorexia, right? Anorexia. I feel like it would cause the opposite, not anorexia. I'm gonna go with altered skin. Psychiatric. What? Okay, I got that completely wrong. Psychiatric reactions. Long-term effects. I didn't know that was a thing. What rhymes with purple? I have no flipping idea. I think it's one of those weird ones that you just have to rhyme it with something weird. Like, I like fruit that's purple. it makes my tummy very full. I don't know. Just made up some nonsense. Okay, anyways. Which of the following chemotherapy agents is the most strongly associated with this type of dose-dependent cumulative cardiotoxicity? Cardiotoxicity, I don't know. Cisplatin, cyclophosphamide. What's my site called? I'm gonna hide it forever. I think it might be paclitaxel. Doxorubicin. Wait, rubicins actually do that. Cause cumulative dose-dependent cardiotoxicity with reduced LVEF and dilated cardiomyopathy. Another one wrong again. Wrong. Another one wrong again. Which electrolyte abnormality is most characteristic of refeeding syndrome? Malnourished, post-prolonged, parental intake, rapid electrolyte decline, refeeding syndrome. Okay, you're getting all this food in. Sodium D E phosphatemia. Oh man, that's kind of obvious, right? No, never mind. I don't know that because the intracellular shift of phosphate, potassium, and magnesium. Wait, what? Oh, hypophosphatemia. I might have guessed that if I saw it said hypo. I thought they all said hyper. Are you kidding me, man? Refeeding causes an intracellular shift of phosphate. What is the most appropriate course of action? 17-year-old male requests EHC for his 16-year-old girlfriend who is too embarrassed to come herself. Okay. Advise him that his girlfriend should come to the pharmacy for consultation to ensure that EHC is clinically appropriate. By the EHC and advise him to take it, refuse to sell it, and advise him to another pharmacy refuse to sell the EHC. Go to the case to police. 17 and 16-year-old. I actually don't know. Wait, what are the guidance behind that? Sell the EHC without, as he is within the illegal age. I think she has to be present. A. That's kind of dumb, isn't it? I need to actually just see something about this. What ages would be concerning? Of course 13, but I'm talking about like if she was 16 and what 17 or 15 is generally viewed as peer on peer. So 15 is fine apparently if you're 17. Could still provide it under the PGD, but only if she attends in person. Fraser competence. If they're 18 and 15. So is it just 2-year gap basically? So more than 2-year gap. An age gap of more than 2 years is exactly where UK clinical safeguarding tells professionals to pay close attention. I thought so. If a 14-year-old presents with a 17-year-old, oh yeah, that does not sound This sounds a bit noncy. Okay. Interesting. Okay, okay. So I got that right. That's good. What is the following is the most appropriate product or advice for this patient? Sharp burning pain on one side of the back. Acyclovir for rash in the same area. Sharp burning pain. Can I get the Mafia Kingpin roll? Isn't that if you get to level 100? Yeah, I think Kingpin roll is if you get to level 100. Yeah, good luck. I can't remember actually, but I think it was 100. I think there's only like 2 people that's got it. I can't give that away like sweets. That one's way too difficult to get. Capsaicin cocodamol tablets. Request prescription. It's not level 100? What is it? What is it? I'm pretty sure it's level 100, right? It's gotta be. What does that even mean? Translate, dude. Is that what that means? Translate. That's just the translate button to me. Okay, I'm gonna sell him sharp burning pain on the side of back capsaicin probably. That sounds right. C. Okay, never mind. It's cocodamol. Zoster pain. How's that supposed to know as a Zoster? Oh, it's an acyclovir. Flipping heck, man. But actually, I wouldn't have known. That can be with weaker opioid. Capsaicin and for post-herpetic neuralgia. Okay, Zoster. So you can use cocodamol for Zoster. Everyone who has it doesn't even talk in their DC. It's me and Star that have it, isn't it? It's just 2 people that have it. How do I even check? How do I check who has it roll? It's literally just 2 people. Rolls. Mafia Kingpin. Yeah, literally 2 people, me and Star. You have to be level 100. That is a difficult roll to get. / leaderboard. Let's have a look. Oh wait, you've already done it. But Noodle literally talks so much, he hasn't even got it. Half of these people, I mean, Electric, he like talks so much. I don't know how he has not even got anywhere near level 100 yet. That doesn't even make any sense. Anyways. So that was wrong again. What is the following most appropriate advice you'd give? Reduced appetite more high than usual. Yellow whites. Ooh, yellow whites of eyes. On folic acid and methotrexate. Ooh. She looks like she has liver toxicity. Recommend brightening eye drops. No. I think she needs to be referred. Jaundice. 3. 71, which is the following treatments is true. Give me 8 levels so I can be on the leaderboard. 8 levels isn't too hard, especially at your level. At your level, it's not hard. For me, I get that. I get like a level every like month at this point. Actually, every like couple months. Every month or a couple months. Okay, I've lost my pen lid now. That's great. Oh man, why'd I have to lose the pen lid? Oh well. Oh well, which of the following data protections, GDPR, anonymous? Oh my gosh, I hate these types of questions. I can't be able to read them. 2018 and UK GDPR, anonymized patient data. Is also subject. The thing is, I don't even talk in DC no more. Really? Why? Why is that so? Then why do you want the role anyway? If you don't even use DC anymore. I think it's because I probably don't even stream. There's nothing to talk about. Consent by default. Acceptable? No.
Handwritten records are not subject to the requirements. Patient consent must be sought every time before accessing. E looks like it's right. Patient consent must be sought every time. E. Okay, then never mind, it's wrong. Oh man, because you can say patient best interest. I want the roll just to flex. then if I give it out to people, then it doesn't become something to flex in it. What is the frequency of hepatitis and cholestatic jaundice as a side effect of flucloxacillin? Hepatitis and cholestatic jaundice as a side effect. What's the frequency? Frequency is yellow card is submitted. Wait, what? Wait, he's gonna say in the side effects. Where is the side effects? Cholestatic. Oh man, do I have to like literally read through this now? Come on, man. Cholestatic. Hepatitis cholestatic. Very rare. So very rare. It normally tells you what very rare means. Very rare means 1 in 10,000. 1 in 10,000. Oh. Means less than 1 in 10,000. E. Thank God I got that one right, because that would have been dumb if I didn't. What is the recommendation application time for mechanical cleansing of leg ulcers? How am I supposed to know? Oh, it tells you. I have to read through these, man, because they take me too long. I mean, the 3 marks in the exam, but recommended application time. For mechanical cleanse. Where would it even say? For leg ulcers. Leg ulcers, mechanical application time 30 to 60 minutes. C. Okay, they give me 3 marks now, so that's nice of them, even though I don't deserve them. What is the most appropriate advice regarding bridging contraception during their transition period? A 30-year-old woman on desogestrel correctly to date, switching to copper IUD next week. Stop desogestrel, rely on the copper as a primary immediately after insertion without needing any additional contraception. Stop desogestrel immediately, switch to combine oral contraception until no. Stop just immediately and use no. Continue until it's inserted. And no additional. Continue until inserted and use additional such as 100 for 7 days after insertion to ensure continuous protection. I don't think you need all that. You just continue until it's inserted. D. Is effective immediately on insertion. Yeah, exactly. So D. Bro wants a roll to flex. What is the most appropriate total daily dose of oral morphine? Oh man. I hate this, so rubbish. Actually, this one's not too bad. 40 milligram BD, so that's 80 milligram. W new profile pic. I just AI generated is rubbish. It's a rubbish one. 80 milligram. Switch to oral. 80 milligram. Divide by 2. Wait. 80 milligram. That means 160. 160 divided by divided by 4 times by 3. 160 divided by 4 is 40 times by 3 is 120 daily. Why am I not using my calculator? Bro, at least I got it right, but that would have pissed me off if I didn't get it right. Let's see. Which of the following would be the best appropriate dose to give the patient daily? 48-year-old man. What? Why are you distracting me, stupid emails? Okay. I don't want to. I can't read flipping Twitter, but I got a notification for Twitter and it looked kind of funny, but I couldn't click on it. That's annoying. Which of the following would be? It said like, "Congratulations, Elon Musk," but I'm sure that guy was being sarcastic. It's from Jerry Rig Everything. He hates Elon Musk. Which of the following would be most appropriate dose to give a patient today? Oh man, not this. Body weight 65. PM 129. Low ferritin. Maximum dose must not exceed 20 milligram per kilogram. Per Cosmofor table for body weight 65 kilogram. With HP content of 19 equals 5.6. What? What is this even talking about? Okay. I think you just have to work backwards. For 1450. Okay, let's use 1450 divided by 65 equals 22. So you have to split the dosing. So 1450. Shoot, I don't know now. You just split. So how do you split the dosing? It didn't tell you. So you just say 1000. I say 1000 then. Go with A. Okay, I got it wrong. That was easy. That was an easy question I got wrong. And it's so dumb how I got it wrong. Oh man. I've lost about 9 marks to just easy dumbass questions. Which of the following is not an hormone therapy for prostate cancer? Anastrozole? That looks. I'm pretty sure that's for breast cancer. Bro, I don't know. I shouldn't know this. Bro, I mean, I can know this, but like that was a guess. I would have. Oh wow, I would have got that wrong in the actual exam. Oh well. So I'm getting the hard questions right. Which of the following insulins would be appropriate for bolus dosing in basal bolus? Basal bolus regimen. For bolus dosing though. Glargine. They want basal bolus. So isn't that like mixed? So is it not Insulatard? I'm gonna go with Insulatard because all the other ones look kind of long ones. Insulatard. No, Lispro. Which of the following would be the most appropriate for? How am I reading this so wrong? Bro, I can't read. I read most appropriate for basal dosing. I just can't read, chat. This is just pissing me off, man. I've lost 10 marks just to easy ass questions. Oh my gosh, man. I read that as basal, not bolus. Which of the following accumulates due to slower metabolism in infants? Accumulates. actually don't know this one. Accumulates primidone, lamotrigine. Oh, she's breastfeeding. Tonic clonic. An anti-epileptic for tonic clonic. Slow metabolism. I would just go with it could be like primidone or something, or zon. I'm gonna go with zonisamide because I'm ahead of it. What's lamotrigine? Lamotrigine is metabolized more slowly in young infants and may accumulate in breastfed babies, requiring monitoring for adverse effects. Right. Which of the following is the correct hourly infusion rate for the patient? 3-week-old baby, IV trinitrate to maintain safe blood pressure, weight 2.4, initial dose is 0.2 micrograms per kilogram. 0.2 divided by 5 is... Wait, what? Oh, sorry, 0.4. Okay. 0.4. Wait, what? Oh, yeah, let me use my calculator for once. That'd be nice if I actually use my calculator, wouldn't it? 0.48 per minute. So you times it by 60. 28.8 D. Bro, that one is a tricky one in terms of, not tricky in terms of the calculation. Like, they're trying to trick you out by putting per minute or per hour. Okay, 81. How long have we got left? 40 minutes, and we've got 40 questions left. That's great. Is likely to require chronic iron supplementation rather than the temporary course, ordering prescribed iron supplements. Athletes engaging in their intense celiac disease, hereditary comatosis, rich in red meat and leafy greens, vegetarians who consume fortified foods. I'm saying the celiac disease. B. Causes ongoing iron malabsorption even on a gluten-free diet. Iron overload. You know, the problem is I feel like I'm getting so much of these right that they're not going to choose these types of questions on the actual exam. Which of the following is most likely to be prescribed for this patient to address an identified issue? Female to male transgender patient on testosterone HRT. Increase the body hair and deepen. Why am I being told all this? For what? Identified issue. Prompt consideration of additional medication for potential side effect. What's the additional side effect? Oh, is it something to do with routine blood test prompt consideration? I have a feeling. Is it something to do with thyroid? Or could it be estradiol? I think it might be the estradiol. I'm not going to play it safe and play estradiol. Unless finasteride. Testosterone HRT can cause androgenic alopecia. Finasteride is used to manage this without compromising masculinizing effects. Surely the alopecia would make you look more manly, right? You know, I'm not even going to go there. Whatever. Okay, so... which of the following treatments would be most appropriate for managing this patient's symptoms? Intermittent facial redness across three cheeks, burning stinginess sensations, erythema, broken. So this looks like rosacea. What do you actually use for rosacea? I actually don't know. Oral chlorphenamine, topical clindamycin. So it could be from mites on your skin, but I think it's normally metronidazole or hydrocortisone. So it's not going to be any of the antibiotics. Chlorphenamine is an option. Okay, is it? I think so. Tetanoin. Maybe. hydrocortisone. It's a female though. 38. So topical tretinoin, maybe not. I'm gonna go with oral cloth, and that would make us sleepy. Is it topical hydrocortisone? It can't be. Okay, D. Metronidazole. Topical steroids worsen rosacea and should be avoided. Well, I chose the flipping red flag option, so that's wrong. Wait, what? So I need to actually look at the flipping treatment for that. That would be nice. So use metronidazole and ivermectin. What? For rosacea. Which of the following is the most appropriate action to take? Hypothyroidism, levothyroxine. Her bloods are showing. Let's have a look at the T4. T4 isn't even that high, so she needs to increase it. Ooh, but TSH is high. TSH is high. T4 is low. Increase the levothyroxine dose. Why is there lithium? I don't know when you start lithium. But I'm gonna go with. I'm gonna go with increased levothyroxine dose. So that's B. What is the most appropriate management? A 60-year-old man started allopurinol for gout. 2 weeks later, another gout attack. Oh. Continue allopurinol, treat with colchicine, increase allopurinol dose, stop allopurinol, stop allopurinol, switch allopurinol to febuxostat. 2 weeks later, another acute gout attack. Would you just treat it? You need to treat it though. None of the other ones have treat. I'm gonna go with continue allopurinol and treat A. Allopurinol should not be stopped or changed during an acute flare. The flare is treated with the colchicine or NSAID. Urate lowering therapy is continued at current dose. Well, I got that right. I don't know if I deserved it. Which entry best meets controlled drug register requirements? Let's see, is this right? Oxlane invoice number, quantity received. Did they not? I swear that one needs something else. This. Yes, yes. Quantity supplied. Signature. Bro, why can I not figure out what's wrong with this? All of this seems fine to me, which is really dumb. Margaret Eldridge is wrong. Wait, is it the one that's wrong? Please be the one that's wrong, because all of these look wrong, right? Best meets the requirements. None of them? That one's the one that was wrong. Name and address from whom received. Cox Lane. Invoice number this. Chat, I'm wasting so much time. I think name and address of healthcare professional. So that one's wrong. That one's wrong. It's got to be number 2, isn't it? Number B. I don't know why though. I forgot what the first one's missing. Shall I just give us this ChatGPT? Capture ChatGPT. Let's see how good it is going to be at this. Which is the best entry? Most complete. Entries reviewed. Balance of data. However, several fields are empty. The 7th. Bro, ChatGPT got it completely wrong. Oh well. Dumb ChatGPT, bro. I hate how confident it is as well. Pisses me off. How long after taking Elevistone should you wait before breastfeeding again? Ooh. Requesting EAC. She can breastfeed straight away, I think, right? E. Yeah. No longer requires interruption. She can start breastfeeding straight away. What is the biggest risk in this situation? Parkinson's disease, co-carol-dopa dose has been delayed. Co-carol-dopa dose has been delayed. You get, oh yeah, you get neuroleptic malignant syndrome. E. We learnt about that today. What is the most likely skin condition? Corners of mouth cracked and red. Recently fitted with 3. It's not molluscum, it's not impetigo. Is it angular cheilitis? Perleche. Causing salivation maceration, angular cheilitis. Which of the following vitamins is most recommended for older adults to maintain bone health? Ascorbic acid, which is vitamin C, ergocalciferol. I don't know which one that one is. Retinol, vitamin A, thiamine, B1, tocopherol. I'm gonna go with ergocalciferol because that sounds like vitamin D. Or vitamin, yeah, vitamin. I don't know what ergocalciferol is, but yeah. Ergocalciferol is called calciferol. I thought so. They're trying to trick me out, bruh. Flipping idiots. For each of the patients described, select the most appropriate treatment from the list above. 67-year-old man with heart failure with reduced ejection fraction starts complaining of breast tenderness and visible enlargement. He has been stable on which medicine? It's probably spironolactone. Yep. Spironolactone. 3. Recently started antihypertensive medication. She now reports persistent dry cough. Probably Ramipril if it's there. Ramipril. Bro, some of these are so easy. I love them. These are nice. Hypertension, migraine, prophylaxis. He's experienced vivid dreams, nightmares. Let's see what he's got. There's propranolol there. Probably propranolol. E. Come on, man. These are too easy, bro. Too easy. Chronic heart failure presents with breathlessness, bilateral ankle swelling. Sounds like amlodipine. Ooh, actually, chronic heart failure. Weight gain over the past few weeks. Chronic heart failure can still cause it, but I'd say it's still amlodipine. Oh, furosemide. Weight gain. Increased breathlessness. Oh, relieve her symptoms. Bro, I would have known that, man. Should I say that I was right? No, forget it, man. I'm just going to put it wrong and then put it on the mark that I could have got an easy question right. I need to actually read the question, maybe that's why. 69-year-old man, atrial fibrillation, requires rate control. He is unable to tolerate beta blockers due to severe bronchospasm. Which medication is most work for his rate control? So not bisoprolol. Rapamil. H. When beta blockers are contraindicated, rate limited is good. Okay. What question are we on now? 96. How long have we got? That yeah, half an hour. Oh man. 12-year-old asthmatic boy states that he's smaller than his classmates at school. Select the drug most likely to cause his shunting. I actually don't know this one. Shunting. It could be the steroid, or it could be the montelukast. He's asthmatic. Montelukast, I'm gonna go with. No, it's a steroid. I knew it. Okay. Well, reports that 14-year-old son has been having worsening mood swings, nightmares, and thoughts of self-harm. That's the montelukast in it. Right, if I read the next question, then I would have known it's not montelukast for the last question. Anticoagulation. Okay, I need to actually go through anticoagulation because I don't know. 15 started on oral anticoagulant. He is advised that the medicine should be taken with food to ensure adequate absorption. Which medicine? That's rivaroxaban if it's there. Is it not there? It is. F. Ooh, bioavailability drops to 60%, 66%. That's an interesting fact. Let me just write that down. Rivaroxaban. Drops. No food. Okay. 99. A 32-year-old woman who is 20 weeks pregnant presents with confirmed DVT. She has no significant past. Which anticoagulation is most appropriate? DVT confirmed. Ooh. Apixaban I would give, but let's see what else is there. 20 weeks pregnant. Actually, I'm not sure. Normally you give it a Nox for pregnancy. So is it just fondaparinux? I actually am not sure. I'm gonna go with fondaparinux D. I actually don't know. It's tinzaparin. So was it Nox? So okay. Anticoagulation of choice. Low molecular weight. I didn't know that was low molecular weight though, but I guess it's in the name, in it. Fondaparinux, I thought maybe. Okay, whatever. So wrong. I knew it was gonna be a enoxaparin, man. The enoxaparin sounding one. It's prescribed metronidazole for dental infection. Long-term anticoagulation for. It is a inhibitor. So warfarin. H. 3. I didn't even read the question there, so hospitalized patient. Okay, never mind. A hospitalized patient develops significant bleeding following a surgical procedure. Considers using protamine sulfate to reverse the patient's VT prophylaxis treatment. Which medicine is the patient most likely receiving? Protamine sulfate. Protamine, what do you use that for? Protamine. Protamine is used for which one? VTE prophylaxis treatment. Is it going to be the Fondaparinux? VTE prophylaxis. I don't know, Fondaparinux. I'm just going to guess that one. Tinzaparin again. Bro, it's because it's written Tinzaparin instead of flipping enoxaparin. I would have guessed enoxaparin if it was there. Is the antidote for unfractioned heparin and partially reverses Fondaparinux is not reversed by protamine. DOACs and the warfarin have their own specific ones. DOAC is Andanex alpha. Dexacusumab. No, Andanex alpha is Fondaparinux. Edoxacusumab is DOAX. Vitamin K is for warfarin. I need to go through that because that sounds like it's going to come up. The tinzaparin is for. No, so they get protamine. Okay. 68-year-old man is prescribed a proton pump inhibitor for gastroprotection while receiving treatment following an acute coronary syndrome. The pharmacist identifies a clinically significant interaction. So PPI, which medicine is most likely involved? Clopidogrel. Ooh, too tidy. Central nervous system, prolonged QTC. Ooh, we just did this as well, so this is kind of bad that I don't know it. Prolonged QTC. What did I remember just doing one of these and they said that. I think it might have been the. Who requires rapid tranquilization. Oh! She needs rapid tranquilization. I didn't read that. It's going to be lorazepam then, isn't it? Should be avoided, right? Yeah. IM lorazepam is for particularly in older adults. Okay. 64-year-old man being treated for acute agitation and alcohol withdrawal. Ooh. Being acute agitation. I went through alcohol. Man, that was another one. That was what we're going to go through next. Alcohol withdrawal. Acute agitation. I would say it's either. I'm going to go with haloperidol. I don't know why, but haloperidol sounds right. Long-acting benzodiazepines. So diazepam then. And the mainstay of managing acute with alcohol withdrawal to cost tolerance with alcohol and smooth taper. Chlordiazepoxide is first-line. Diazepam is an accepted alternative. Diazepam is reserved for patients with significant hepatic impairment, where long-acting agents would accumulate. It's reserved for patients with significant hepatic, where long-acting agents would accumulate. Okay. Severely agitated who's already on clozapine. Already on clozapine. You can't put them on another flipping antipsychotic then, can you? I actually have no flipping clue. Diazepam. I'll go with diazepam. Or lorazepam again. Benzodiazepine alone is preferred for rapid tranquilization in a patient already on clozapine. Combining clozapine with additional antipsychotics, especially olanzapine, is bad. There's risk of cardiorespiratory collapse. Lorazepam alone is the safest option. Okay. Bro, I didn't think it could be Lorazepam again. Oh man, what? I thought these were easy questions. Why is there another dumb question? Oh man, is it one of these? Please, man, I don't want to do this. Oh man, infected carditis. I don't want to do this. I have to look at back and forth between this PDF and flipping all this nonsense. On the recommendation of microbiologist, vancomycin has been selected for treatment. A doctor on the ward has asked for a Chicago to vancomycin maintenance dose 81 kilograms and 73 mils per minute. What is all this? 81 kilograms. So you want some maintenance dose? 81 kilograms, 73. Where is his weight? What? Didn't talk about his weight. Oh well, maintenance dose 73. 73. The dose of vancomycin 750, 12 hours, 250 mil. 750, 12 hours. It's got to be G. Thank God for that, because I was not going to waste so much time doing nothing. Osteomyelitis, prescribed it. Planned for trophic levels pre-dose to be short. Safe dosing 71. Actual body weight of 95. Appropriate loading dose. So 95, 71. Is that his actual body weight? I don't know. 2 grams in 500 mils. Osteomyelitis, trophic levels. I think it's got to be just the E. Okay. Mrs. Y is being treated with vancomycin with Staph aureus and it's responding well. Part of routine monitoring, a trough sample was taken. Next dose was administered. The concentration come back as 13 milligrams. Is it not supposed to be between 10 and 15? I thought. Is that going to be the trough before the next dose was administered? Standard range is 10 to 20. But for staph infections, then it's supposed to be 15. Did you say she's got staph? Okay. Discuss with microbiologists if you're unsure what target to use. Why doesn't it just tell me what to do? I guess you're gonna have to increase it though, but I don't know where it says that. So increase the dose by 50% is crazy though. Oh well. It's got to be that one. A or B. Maintain the present dosage regimen. Target trough for uncomplicated Staph aureus is 10 to 15. 15 to 24. What? Deep seated. What? Did it not just say for staph infections or deep? Standard range is 10 to 20. Exceptions for staph infections or deep sea. Is that not all? Uncomplicated. I think this one's wrong, but oh well. Oh well, okay, whatever. How long we got? 15 minutes. How long? How is this taking up to the wire? Normally I do these so quick. Oh man, how many more? For the patients described below, select the most likely condition for the list provided. Presents at the pharmacy requesting ingestion remedy. Suffering from heartburn for nearly 4 weeks. He has tried Gaviscon. Did not help. Unexplained weight loss. That's not a cancer. G. 3. Stuff's where she has constipated recently and been straining, but she has recently noticed bright red blood. That's not like hemorrhoids. E. Come back from appointment with her GP with a prescription for the following medications: omeprazole. Okay, that sounds like H. pylori. Okay. The confirmed diagnosis of asthma has been using beclomethasone 2 pills twice a day. Despite good illness, he reports using salvia more than 3 times a week. Waking up. What the hell? This is the old guidance. What would be the next test? I think switch to Mart. I'm gonna go H. Well, that was right, even though I didn't read the question properly. Maybe I should, to be honest. Has asthma that is not well controlled despite taking a low dose of ICS and Montelukast at night. For 2 months, she has. Sound like this person needs to be on Mart as well. He has symptoms at night once a week and uses her salbutamol 4 times a week. What's the next step? Can't I not just put this person on Mart as well? 4 times per week. Yeah, I'm gonna put her on Mart. Let's go. 114 high dose ICS lava, and okay. Bro, all of these look like they need to be on Mart. Yeah, 2 exacerbations requiring oral steroids and lasting materials. What's the most appropriate next step? High dose ICS lava and a liquid train antagonist. Would it not be Mart again? Are they trolling? They must be trolling. I'm gonna go Mart again. Although, actually, he's on high dose. High dose ICS and liquid train and lava. What's he gonna get from a llama? Still, though, he could still get a. I'm gonna go Mart. No, it's refer. Okay, well, my luck ran out by just putting them on Mart. Refer to considered biologics if they're on high dose despite good adherence. Oh, he's not on the llama though. Oh well. 7-year-old, low dose ICS twice daily with salbutamol for 3 months. Despite good adherence, she has asthma symptoms, wakes up at night. She is unable to manage a MART regimen. I wish you would have MART regimen. She's 7 years old. What is he talking about? Using low dose inhale twice daily. Salbutamol. I actually don't know what's next for them. Do you put them on LABA? I guess increase the steroid dose in it. D. Oh. You have to put them on leukotriene before increasing the dose. Interesting. Lipid modification. For each of the statements below, select the single most appropriate one. Has recently been discharged after myocardial infarction. Wait, let me just write the last one down. So leukotriene agonist before increasing ICS. Anyways, has been recently discharged after a myocardial infarction. His total cholesterol is 6.2 and his LDL is 4.1. He's currently on clopidogrel aspirin. What is the most appropriate lipid lowering treatment? He's not even on any lipid lowering treatment. He's been discharged with myocardial infarction. He needs atorvastatin 80. Yeah. Familial hypercholesteremia. 80 remains the appropriate next step. You can put in bempedoic acid as well. Ezetimibe in it. Oh, you could put in PCSK9. I think inclisiran as well. But I think bempedoic acid first, right? See? No, you can go straight for the PC. So with primary FH, despite maximally tolerated statin plus ezetimibe, recommend. Glycerin is restricted. Second prevention is not recommended in primary FH alone. Okay, so you can go with the PCSK9 inhibitor, Arilicumab. PCSK9 for primary FH. Okay. Woman with history of stable angina and Q risk of 25% has been unable to tolerate multiple statins due to severe myalgia. She's been taking ezetimibe once daily for those 3 months, but her LDL remains high. And she got stable angina. She can go on bempedoic, right? Yeah, see. Okay. Osteoporosis management. 69-year-old prefers a less frequent oral dosing option from the list. Alendronic acid tablets. But she doesn't want. She wants oral. So that means I'd go with alendronic acid. Oh, ibandronate is monthly compared to weekly alendronic or risandronate. Oh, ibandronate is monthly. I didn't even heard of that one. Monthly. Cross. And then finally we have been taking alendronic for 5 years. Risk is now low and bonus improved. 5 years. Don't she need like a... I'd switch it to the calcium vitamin D supplementation only. B is now low. I think I'll just continue it on it, right? Or with this discontinue treatment. I'll go with B, but discontinue treatment or calcium and supplementation. I think the fact that they're saying is now low means that they don't want me to keep on calcium, vitamin D. Do I game the system or do I do what I would say? I'll do what I'll say. B. Oh, is it discontinue? Of course it is. You wouldn't put them on flipping vitamin D. Oh, come on. Alright, chat, so that's the exam finished. Let's see what I got. It doesn't look that good. It doesn't look good at all, to be honest. Let's see. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Wait, let me just count that again. 1, 2, 3, 4, 5, 6, 7, 7. 1, 2, 3, 4, 5, 6, 6. 1, 2, 3, 3. Oh, what's that? 13? Is it? Yeah, 13. 16. 16. Times by 5 equals, yo, 86. About 86, have I? 30 plus 58. 50 plus 30, 80. 2 plus 4, 6. 86. Plus, how many marks did I make? Shit. I've been counting those. Shoot. I don't know how many marks I've got wrong. Okay, let me just... I've accidentally counted the marks I was giving. I was saying that... Oh, man. Let me count all the ones I got wrong instead. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44. 44. 120 minus 44 is 76. Oh, shoot. 76. 76 divided by 120 is 0.63. What was the pass mark again? Pass mark for GPHC exam. Requires 77 out of 79. GPHC pass mark reaches 77%. Oh no, never mind. Oh, 77 out of 79. I got 76. Which is 63%. I mean, it's an improvement for the last one. I got 74 on the last one, but I got 76 on this one. Shoot, man. RPS 26, 74 out of 120. Green light 26. I got 76 out of 120. You can only go up from here, right? I mean, maybe these are the easy ones though, so that's what I'm not looking forward to. GPHC.
What did I get for that? GPHC star. So I got 13. 13 times by 6 is 78. It's not looking good, man. Shut up. 70% is what I'm trying to get. I'm getting around. How's 76 out of 120? 63%. 63%, bro. That's bad. But if the GPHC one's accurate, 78 or 120, that's just under passing. No, that is passing 77 to 79. Okay, I mean, I can still carry on going through content tomorrow, so it's 1 a.m. I'm gonna go pray. I need to go through the other stuff as well, don't I? What did I lose a lot of marks to? I'm not sure. I need to write down what I've lost more marks to. Like we're barely like passing the. I mean, we're scraping it. I don't know what we need to do to increase it. All right, chat. I will see you all tomorrow then. Whenever that is. Bye.